Morning, everyone. So here we are. We're into our fifth lecture, and today we're going to go and explore and see how we diagnose, assess, and treat several different cancers, namely liver cancer, stomach cancer, and colorectal cancer. And so what I'll do is I'll post us links on a couple of the videos that we're going to look first, and then we're going to dive into our textbook and see specific assessments, diagnosis, and treatment. First to a liver cancer. So let me just post these videos links. Okay, so let's start with first medical visual animation that introduces us to a liver tumor in cancers.
Today's topic is liver tumor. A liver tumor is the abnormal growth of cells on or in the liver. The liver is the largest internal organ of our body. It aids in metabolism, digestion, immunity, and storage of essential nutrients within the body. The liver is an essential part of the body. Without the functions, the tissues in the body are liable to die from insufficient energy and nutrient. The liver is made up of various cell types, therefore several distinct types of tumor can develop on the liver. These abnormal growths may be benign, or non-cancerous, or malignant, cancerous. There are several types of benign liver tumor, such as hemangioma, hepatic adenoma, or focal nodular hyperplasia. Hemangiomas are the most common type of benign liver tumor, and focal nodular hyperplasia is the second most common benign liver tumor. A malignant tumor is cancerous and can spread cancer cells all over the body. A malignant or cancerous tumor may be either primary or secondary. A malignant primary liver tumor is a cancerous tumor that begins in the liver. A malignant secondary liver tumor begins in another part of the body and metastasizes or spreads to the liver. Most cases of malignant liver tumors are secondary. They are metastases from other tumors such as colon cancer, breast cancer, ovarian cancer, lung cancer, prostate cancer, etc. There are different types of malignant primary tumors, such as hepatocellular carcinoma, which is the most frequent. Other types of malignant primary liver tumor are rare, and they include cholangiocarcinoma, sarcoma, mixed tumors, and hepatoblastoma. Causes. The exact cause of liver tumor is unknown. However, risk factors that may increase the chance of developing the condition include exposure to toxic chemicals such as arsenic. The use of oral contraceptive is associated with some benign liver tumor. Steroid abuse, alcoholism, cirrhosis, hemochromatosis, poisons produced by molds that grow on improperly stored peanuts and grains, or aflatoxins, chronic infection with hepatitis B virus, HBV, or hepatitis C virus, HCV, certain inherited liver disease. Diabetes can increase the chance of malignant liver tumor. Accumulation of fat in the liver, or non-alcoholic fatty liver disease. Symptoms. There are usually no symptoms in the early stage. Once symptoms are present, they may include abdominal pain or discomfort, usually on the upper right portion of the abdomen, loss of appetite, weight loss, fever, profuse sweating, feeling unwell, nausea and vomiting, anemia with pale skin and lips, jaundice, itchy skin. Diagnosis and treatment. To make a diagnosis, the patient's medical history and a physical examination are needed. During the physical exam, The doctor will press upon the liver to detect any swelling or solid mass. A blood test is taken. This may reveal the function of the liver. Imaging tests such as ultrasound, CT scan, and MRI may be done. A liver biopsy may be performed. During this procedure, a tissue from the liver is removed for testing in the laboratory. Treatment. Surgery may be used to remove both benign tumor and malignant tumor. For large malignant tumor or widespread cancer, surgery is not advised. Chemotherapy that involves using medication injected intravenously or taken orally to kill the cancer cell. Radiation therapy that uses powerful energy beams such as X-rays to kill the cancer cell. Immunotherapy, also called biological therapy, that uses treatments that help the autoimmune system recognize and attack abnormal cells. Liver transplantation is a rare option. Thank you for watching our video. Please do.
Okay, so that was a short video explaining some of the forms of malignant and benign tumors growing in the liver. So we're going to look at the short video explaining us some of the TCM sort of Chinese medicine look at it.
The liver, the most important of 5 organs in the body, is called the equivalent of 1,000 soldiers in Oriental medicine. It is about the size of one's palms put together and weighs 1/50th of one's body weight. Chronic or acute hepatitis, hepatocirrhosis, liver cancer or fatty liver, of which a liver cancer is the hardest to cure. Everyone becomes interested in health as they get aged, and the liver is the organ that makes you realize how aged you are, which is what everyone feels at least once when they are over 40. We're going to find out how they approach this liver cancer, which is said to have the highest occurrence rate and death rate, and also what the treatment methods are. Liver cancer is a disease where the liver cells start to go bad and spread until they are destroyed, and the whole liver becomes a lump of cancerous cells.
In Oriental medicine, there are several names for liver cancer, depending on the different symptoms. Malignant tumor in the abdominal cavity is called 진가적취. Symptoms of vomiting is called 열격 or 반위. And if there is external signs on the skin, it is called 실령 영유.
Like other types of cancer, liver cancer is diagnosed based on symptoms. 진가적취 is where a tumor can be felt in the stomach, intestines, liver, gallbladder, pancreas, pelvis, or peritoneum. This could mean cancer of stomach, liver, womb, ovaries, or big intestine. When the liver goes bad, exhaustion comes easily, especially in the eyes. Other signs include indigestion, rough complexion, dull hair, and loss of hair.
그런데 우리가 피로해가지고 이제 잠자리를 들어도 7시간, 8시간 자고 아침에 일어나 눈을 떠봐도 몸이 또 무거워 깨어나지를 못하고 무거워 있어요.
담배 좀 많이 피우고.
예. 그래서 초기에는 이거는 뭐 큰 증상이 없어요. 그래 전문가들 이제 이제 진찰을 해보면은 뭐 GOT, GPT 이런 게 이제 많이 올라가게 되고 또 맥을 보게 되면 이게 굉장히 긴 혈맥이 나와요. 맥이 약해요 좀. 네. 눈알을 이렇게 이제 까보면은 좀 누런 면이 있다든가 이렇게 표면같이 이렇게 거칠고 조밀하지를 못해 사람이. 그런 경우고 또 심하면 이제 뭐 코피나 뭐 피도 좀 나는 수도 있고.
There are many telltale signs of a bad liver, including occasional nose bleeding, lasting bruises on the shin, blackening finger and toenails. The chest feels stuffy, and for men, there is a decrease in libido. In the early stages, these signs are usually ignored, unwittingly giving the disease time to grow out of hand. Oriental medicine adopts a unique approach to liver diseases. The most important thing is to discover how severe the case is by taking the patient's pulse. The Okru pulse, which feels like an occasional raindrop that falls through a thatched roof, means that the patient will die in 3 days. In this way, feeling the pulse can give a rough estimation of the severity of the disease. The primary treatments for cancer in Western medicine are an operation, a radioactive treatment, and also anti-cancer treatment. To the contrary, in Oriental medicine, they consider acupuncture, herbal medicine, and folk remedy as a primary treatment. Let's find out about each treatment methods of Oriental medicine.
There's one simple hearing hack anyone can use to improve their hearing almost overnight.
In Oriental medicine, liver cancer is basically treated with herbal brews. The usual prescription is 인진 오령산 with 가감위령탕 added to it. The 16 ingredients include 인진, 진피, and 백출.
치간탕 중에 제일 군약으로서 이것은 인진이라고 속명으로는 사철수기도 합니다. 이거는 간의 비섭을 갖다 제거해주고 이뇨작용을 해주는 제일 군약입니다. 요건 진피라고 하는데 요거는 담을 갖다 제거해주는 작용을 합니다. 요거는 백출은 삽수삭 뿌리를 절편한 것인데 이것에는 위를 갖다가 튼튼하게 해주고 소화작용을 많이 도와주는데 주된 약입니다. 요거는 오미자, 요거 5가지 맛을 낸다고 해서 오미자입니다. 오미자는 간의 GOT, GPT 기능을 갖다가 활성화해주고 하는데 주된 약입니다. 이것은 텍사, 이뇨작용을 수분 배설하고 이뇨작용을 촉진해주는데 제일 중요하게 쓰이는 텍사입니다.
Based on such prescriptions, Oriental medicine has developed many varieties to suit different constitutions.
In Oriental medicine, liver cancer is regarded as a condition where bad blood is mixed in the liver. So treatment aims at recovering the patient's health by clearing up the bad blood, aiding blood circulation and urination, and enhancing biological rhythm. So, the strength of Oriental medicine lies in fundamental therapy. Acupuncture is also used as a supplement to medicinal therapy.
예, 되게 간 환자들은 피곤하기 때문에 혈액순환이 좋도록 우리 한약에서 사관을 넣습니다. 여기 합곡혈입니다. 합곡하고 태충혈을 합해서 우리가 사관혈이라고 합니다. 이쪽 양명이 이게 소화장애가 있기 때문에 소화가 좋도록 족삼리혈.
There are 4 kinds of treatments for cancer, namely surgery, chemotherapy, radiotherapy, and herbal therapy. Eastern and Western therapies can be used simultaneously to achieve more effective results.
Basically, the herbs used in medicinal therapy serves 2 purposes. Firstly, they restore vitality, strengthen the immune system to increase anti-cancer abilities, and restore health. Secondly, they directly work on the cancer cells to suppress their growth.
It is necessary to understand your own constitution first when you have a certain disease. For example, there was a time when the patients with liver disease used to drink the grounded juice of fresh vegetables, but it doesn't apply to anyone because the cold tendency of fresh vegetable juice can bring about a contrary effect for those who have intestinal and digestive disorder. I think we'll be able to get great effect if you are more open-minded, regardless of Western and Oriental medicine, and also regardless of type of cancer, whether it is skin cancer, lung cancer, or liver cancer. I'll see you next time.
Okay, so we're going to look into our textbook now. So as we saw from these two video presentations, there are a number of benign and malignant growths on a liver, and liver being one of the central internal organs, either gets directly tumors to grow on it, or sometimes it's spread from other areas or other organs that eventually through blood affect the liver, because liver is also one of the main detoxing organs in the body. So when we look at clinical manifestation of the liver, we often notice that in an early stage, we have a mild presentations. They're often dismissed as just something that comes and goes. It's usually a moderate stage that people start paying attention. So often fatigue that doesn't go away, low appetite, bloating and distension in abdominal region, pain later on, especially in the right hypochondriac region. Changes in the skin often would look like jaundice, so yellow skin, increase of bilirubin that causes yellowing of the skin, or yellowing of sclera in the eyes. Often lack of overall energy and strength, and then changes in elimination often, such as diarrhea to constipation. Sometimes we see urine that's smaller in a volume but darker and smellier. And then, of course, sudden increase in all symptoms, including the pain, often points to entering different stages, right? And so a loss of weight and overall poor circulation is often a poor sign clinically. So at that point, patients may be treated with various biomedical therapies. So that includes possibly surgery if it's possible, if not, then chemotherapy, radiotherapy, or hormonal targeting therapy. Chinese medicine looks at liver cancers through several different pathophysiological themes. For example, invasion of external cold, or dampness, spleen-Yang deficiency, and often pseudo heat, right? Often nearby organs are affected as well. So spleen, stomach, pancreas, intestines, lung, where the liver basically spreads through blood sharing all these malignant cells. So when we look at the internal treatment of directly treating liver, one of the first symptoms we're looking is liver qi depression and spleen qi deficiency. So we have distension and fullness in abdominal and hypochondriac region, namely the right hypochondrial region, intermittent distension below the diaphragmic hypochondria, oppression and discomfort of the chest area. Often person gets more emotionally and asymptomatically affected when they get angry and irritable. Often there's an acid reflux with bitter taste in the mouth, nausea, belching, and overall emotionally patient is more on a sort of angry or irritable side. So when you look at elimination, often we're looking at mostly diarrhea. Tongue bodies often pale red with thin yellow or white coating, pulses wiry, surging and rapid. Treatment principles are to dredge the liver, regulate liver qi, so basically detox the liver, fortify overall spleen qi, and harmonize also stomach and stomach qi. So prescription that we have here is combination of two herbal formulas that target liver, but also liver in connection with the spleen and stomach. So first one is bupleurum powder for dredging the liver, basically detoxing formula that resets hepatic or liver cells. So that's Chaiwu Shugang-san. And another one is bupleurum and dangwei, or free wonder, as it's sometimes called, Xiaoyao-san, with modifications, Jiajian. So these two formulas target the liver functions, but also harmonize liver relationship with nearby organs, spleen, stomach, pancreas, intestines, lung, and so on. So when we look at the herbs in this formula, we see several groups. So we have vinegar processed bupleurum, right? So it's Chuzaishu, curcuma, Eugene, prunella, Xiaokucao. And these are basically anti-inflammatory, clearing heat herbs, regulating hepatic cells and regulating liver qi. Angelica, Dangwei, Baishao basically resets moisturizing effect and blood chemistry in the liver, so nourishing yin and blood. Huangqin and Yiren are also clearing dampness and the heat. Baizhi and Fulin here are there to harmonize spleen, stomach, and pancreas. Stir-fried pericarpium, so Chao Chen-pi, jerk around to regulate qi of the middle chamber, middle jiao, to better interact with spleen, stomach, and pancreas. And then there are a couple other herbal substances there. So by UH Acabia to dredge the liver hepatic cells and invigorate better blood circulation. And then we have other herbs that are sort of triggering increase in appetite and better nutritive absorption. Zhenei Jiao Shenjia, Jiao Shenchi, Jiao Maya, right? So these combination of these herbs resetting what we call large intestine, small intestine, and stomach function, so-called Yangming, right? So the next syndrome that we're looking at is liver qi stagnation and liver blood stasis. So here pain is very prominent. It's sharp, stabbing, fixed in nature, often in the right hypochondrial region, maybe radiating from front to back or from the liver down or up in the trunk. It's worst at night. There's also associated other symptoms: chest oppression, distension of the abdominal region, low appetite, belching, hiccups, nausea and vomiting. Here we have, instead of diarrhea, we have more constipation. Scanty kind of volume urine, it's smelly and dark. Tongue body is usually purple or dark red, with sublingual veins being purple as well. Maybe teeth marks on the side. Coating is often thin, white, yellowish or grayish. Pulse is deep, thready, and irregular or rough. So treatment principle here is to reset the qi and stagnation blood stasis. So invigorate liver blood, transporting liver blood stasis, move the qi and liver qi and dissipate the lumps. And so again, we're seeing the two herbal formulas combined. So we have Ta Hong Si Wu Tang, so 4-agent decoction enhanced with peach kernel and safflower, and it's combined with Da Huang Zhi Chong Wan Jie Jian, so combined with Rubaru wingless cockroach pill with modification. So again, we have a breakdown of several different groups of herbs. So we have Taoren, Honghua, Chuanxiong, that increase the liver enzyme functions to invigorate the blood and benefit movement of the qi, increasing liver peristalsis. Yizhi, curcuma, Tu Bei Chong, wingless cockroach, basically break up the blood disperse circulation, alleviate the pain. Shunt gu, banjalian, and baichutai clear the heat, so they're anti-inflammatory, detoxing, and they directly reduce basically cancer cell multiplication. Eugene curcuma, Yanhuso cordialis, Bajwe, Kebia invigorate the blood, relieve the liver qi depression, and also reduce the pain to some degree. Da Huang and Zhuke break up the blood stasis and basically regulate the blood and movement of the qi. Chuan Xie detoxes the toxins and inflammatory changes in the liver. Shen Di Huang, Romania, Bai Shao, and Guiban enrich the yin and nourish the blood. So the next syndrome that we're looking at is the one that affects liver through damp heat toxins. So swelling is prominent in upper abdominal region. Distension and fullness in stomach is there as well. When touched, abdominal region and stomach appear tight like a drum. There's a yellowing of the skin, yellowing of the sclera. So basically jaundice-like presentation, irritability, acid reflux with bitter taste in the mouth, nausea, poor appetite, yellow bounce stool, fever and sweating. Tongue is often dark red and dry, sometimes with thick yellow or greasy coating. The pulse is slippery and rapid, could also present as a wiry, slippery, and rapid. So treatment principle here is clearing heat, benefiting movement of dampness, relieving toxicity, and dissipating the lumps. So we have, again, two herbal formulas here. So we have Yinchen Hao Tang, so Oriental Wormwood decoction, and Se Ling Tang Jiejian, Poria 4 decoction. So we have several groups of herbs again. So we have Yinchen Hao, Eugene, Longdang Zhao, Huang Bai to act on heat and dampness and invigorate the blood and reset the jaundice. Chao Zhizi, so fried gardenia, Da Huang, basically clear the heat and drain and purge downward. Pu Gong Ying, dandelion, Along Gui, Dan Shen, they clear the heat, relieve toxicity, and invigorate the blood chemistry. Zi Xie, alismatis, Zhu Ling, Yi Ren, clear the heat through promoting urination or diuresis. Shui Hong Hua Zhe, clear the heat and soften the hardness of the malignant masses on the liver. Hu Po, Ji Nei Jin, Da Fu Pi, Jiao Shenji, Jiao Shenjia, Jiao Shenchi, and Jiao Maya, all reset abdominal and digestive functions and reset the middle jiao. Yin deficiency of both mother, kidney, and child liver is also presented during the malignancy in the liver. So we have continuous dull pain in hypochondrial region, hepatomegaly or enlarged liver, drum distension of fullness in abdominal region, nausea, bitter taste in the mouth, facial complexion, thirst and desire for often colder drinks, low-grade fever, sometimes sensation in chest, palms, and soles, so-called 5-region sweating, mostly in the late afternoon and night, so after 5 p.m. Dizziness, irritability, often there's petechiasis, skin lesions, nosebleeds, bleeding gums, vomiting of the blood, dry or black stool. So we have lots of extravasation of the blood in excretion through urine, through stool, through vomiting. Tongue body is red and dry with peeling, coating, and cracks. And the pulse is deep, tready, and rapid, sometimes surging. So treatment principle is to enrich and supplement both liver and kidney, blood and the yin, and detoxing the liver. So again, we're using the two herbal formulas. So we have Zi Shui, Jing Gan, Yin He. So He means combined with My Wei Di Guang Wan Jie Jian. So beverage for enriching water and clearing the liver combined with Opipogone, and Rehmannia pill, which is the yin tonification herbal formula. So this is a pretty large group of herbs where we have Shendiquang, Jimu, to act anti-inflammatory and enrich the yin and body fluids. Baishao, Hershou, Wu Weizi, Guzhi to basically reset the liver functions and blood chemistry through liver enzyme production. Nutrients, Mai Mendong, Shanzhu, Guiban, Dong Chongsha, nourish both liver and kidney yin. Mudampi, Qishao, Bai Wejia, Hanlian Zhao, Shan He Zhao, and San Qi Fen, not to jinx, and cool and invigorate the blood to stop the bleeding. So they ask us basically more of a thickening agents without coagulating blood too much. Fuling and Zixie are diuretics. So in a small amount, so they don't leach too much of the yin of fluids. Baihua Shishhe Cao, a long way, clear the heat and detox the liver. And of course, he prevents malignant cells from multiplying. Jiao Shenjia, Jiao Shenzhi, Jimaya, again, reset the middle jiao and digestive functions. So these are direct treatments to syndromes of the liver cancer. We rarely use them in the West because patients often go to oncologists first, and they generally come to us after they're under certain Western treatment. So in next chapter, we have hospital proprietary formulas that deal usually with complications of liver cancer. So these are more prominent chief complaints that come up front when a person has moderate or later stage of the liver cancer. So again, these formulas are compiled by experienced physicians, and they don't necessarily have the name. They may call them like ascites treatment formula, or the diarrhea treatment formula number 1 or number 2, and so on. So again, they're there for reference only. Often for us in the West, patients will come post-surgically during radiation or chemotherapy. So again, we may treat them with proprietary formula, or we may use sometimes the patent formulas as well, right? So for example, Tiao Wei Cheng Qi Tang combined with Sheng Mai Yin Jia Jian, so decoction for regulating stomachs and sustaining beverage with modification, with pulse generating beverage, may be a formula that's used post-surgically to help patients recover from removal of the portion of the liver, right? Chemotherapy often does not work as good because of the way that it's administered. So basically, it's used only in a small percentage of the patients because it has lots of hepatotoxic ability. So it kills the liver cells, which are already affected by malignancy. So generally, TCM can be used before and after the surgical procedures. Dietary therapy can play a significant role in treating, and so patients are cautious on what to eat, what not to eat. And so generally food is prepared through a long cooking method, so it's easily digestible. Post-surgically, for example, patient is suggested to eat basically animal and plant-based protein to build basically muscle mass to help recover from blood loss and part of the liver loss, which needs to rejuvenate. Post-radiotherapy, often we prescribe well-cooked hydrating foods, right? So during chemotherapy, we prescribe often eating well-cooked, lighter, kind of easily digestible foods. So During this time, of course, patients are advised to avoid any stimulants, so no caffeine-based drinks, no cigarettes, no alcohol, no spices, because they all have vasodilating and toxic effect, and that could tox the liver even more. Qigong can be prescribed as well. Some of Qigong can be modified, so patients who are post-surgically can be done in a modified laying position if they have enough strength. And then, of course, other Qigong exercises are usually gentle because of, especially post-surgically, because we don't want any internal bleeding, right? So generally, they're either laying or sitting Qigong exercises. So that would conclude our chapter on treatment of assessment, diagnosis, and treatment of liver through our textbook. So I just want to go back a bit and look at one more presentation on liver cancer from Western point of view. So let's have a look at that one.
Hi everyone, this is Dr. Mike. Magandang araw po sa inyong lahat. Have a great day everyone, viewers, subscribers, and followers. This is Dr. Mike based in Hong Kong. And sana po maayos ang araw nyo ngayong araw. And pag-uusapan po natin ngayon ang isang series ng liver discussion natin. Diniscuss po natin previously what fatty liver is all about. Then nag-discuss tayo about the diet for patients with fatty liver. Then, nag-move tayo to non-alcoholic fatty liver disease. And recently, nagkaroon tayo din ng episode about liver cirrhosis. Pag-uusapan po natin ngayon ang liver cancer. Dahil po marami sa ating mga kababayan ang may problemang ganito. Paano nga ba nakukuha ang liver cancer? Ano ba ang iba't ibang uri ng liver cancer na ito? Paano natin nakuha? Paano ang mga simptomas nito? Maring yung mga nanonood sa atin, hindi alam ang mga simptomas nito. Kaagad ba liver cancer? Wala muna siyang pagdadaanan? Kagaya ng mga binanggit natin previously, wala bang liver cirrhosis or fatty liver before siya magkaroon ng liver cancer? Yan po ang pag-uusapan natin ngayong gabi. Sana panoorin niyo itong episode na ito mula umpisa hanggang sa dulo. Before we discuss that, panoorin po muna natin ito.
When home doesn't feel like home, Remedly Health.
Yes, magandang araw po sa inyong lahat. Good day to everyone. Welcome dito sa ating Health Talk by Doc Mike. Our topic for this day is all about liver cancer. The things that you should know about this medical problem. So if you have some friends, relatives, or family members who have this problem, you can share this video para po mas maintindihan nila kung ano ang nangyayari sa kanila. And if you think that this episode would be useful, huwag niyo pong kalimutan i-like, i-share, at mag-subscribe na rin kung bago po kayo dito sa ating channel. I-click lamang po ang notification bell na makikita niyo dyan sa screen ninyo. And mag-comment lang po kung may mga questions.
I'm sorry, I was not aware that it's going to be a dual language. Just trying to see if we can actually have subtitles as English generated right away so we can watch this. Just give me 1 second.
Kayo, sasagutin po natin yan. At para po ma-notify kayo every time na may bago tayong episode. Yung po mga kababayan natin na nag-share ng mga feedbacks nila, comments, suggestion, maraming salamat po. Binabasa ko po lahat yan and I'm trying to answer each of these questions para po sa ating mga kababayan. particularly mga kababayan nating OFWs.
Yeah, this is not gonna work for us because he's speaking partially. Obviously, I think it sounds like Filipino to me. I could be off, or Malaysian, but only part is in English. So what we'll do is we'll remove this video, and we're gonna have a short break. And after we come back, we're gonna continue with a stomach um, presentation. So looking at the stomach cancer. Thank you. Okay, so we're back. We're gonna continue with our exploration of the treatment of the common cancer. So we started with liver, now we're gonna move to stomach. So we're gonna look at a couple medical animations to get us a bit more specific information about the stomach cancer. I'll just post the links here. Okay, let's look at the first one.
Today's topic is stomach cancer. Stomach cancer is the growth of cancerous cells within the lining of the stomach. Stomach cancer usually develops in the mucus forming cells that line the stomach. This type is referred to as adenocarcinoma and accounts for around 90 to 95% of all stomach cancers. Also known as gastric cancer, stomach cancer is the 5th leading cause of cancer and the 3rd leading cause of cancer-related death across the globe. Stomach cancer is difficult to diagnose as it doesn't cause any early symptoms. By the time symptoms occur, cancer would have reached an advanced stage and may have metastasized. Metastasis occurs when cancer spreads to other parts of the body. Stomach cancer is prevalent in East Asia and Eastern Europe and occurs twice as often in males than in females.
And this is mostly in 2 regions because they eat lots of pickled food. And nitrates and smoked meats and pickled food often damages the lining of the stomach, what we call stomachion, and allows for possibility of malignancy growing in the stomach wall.
There are 4 stages of stomach cancer: stage 1, 2, 3, and 4. Cancer at stage 1 is limited to the top layer of tissue lining the inside of the stomach. At stage 2, cancer has spread deeper into the muscle layer of the stomach wall. At stage 3, cancer may have grown through all the stomach layers and spread to structures surrounding the stomach. Stage 4 indicates that cancer has metastasized. Causes. The stomach is an upper part of the digestive tract that is responsible for digestion and the movement of nutrients to the rest of the digestive organs, become cancerous and grow out of control, forming a tumor. There are some risk factors that may predispose an individual to develop these cancerous cells. This may include H. pylori bacterial infection, smoking, stomach polyps, a diet high in salty, pickled, or smoked food, a family history of stomach cancer, lymphoma, tumors in other parts of the digestive system, long-term stomach inflammation. Symptoms: fatigue, severe frequent heartburn, nausea and occasional vomiting, abdominal discomfort, which may worsen after meals, bloody stools, loss of appetite accompanied by weight loss, constant bloating, feeling full after eating a small amount of food, jaundice. Diagnosis and treatment. The doctor will ask about your medical history to see if you have any risk factors for stomach cancer and to know if you have a family member with the disease. To make a diagnosis, your doctor may carry out one or more of the following tests. Imaging test, which may include CT scan and a special type of X-ray called barium swallow. Endoscopy test, to visualize your stomach and look for signs of cancer. If any suspicious areas are found, a biopsy may be done. To check if your cancer has metastasized, exploratory surgery may be performed. Treatment. Your treatment will depend on the stage of your cancer, your preferences, and your overall health. Treatment may include surgery, therapy, and medication. The goal of surgery is to remove all of the cancerous cells in the body of the stomach and some health issues. Options may include removing early-stage tumors from the lining of the stomach, subtotal gastrectomy. For this, only the portion of the stomach affected is removed, total gastrectomy. For this, the entire stomach and some surrounding tissue are removed. Surgery to relieve signs and symptoms. Radiation therapy and chemotherapy may also be used. These procedures are both used to kill cancer cells. Radiation therapy uses a high-powered beam of energy, such as X-rays and protons, to kill cancer cells. Chemotherapy is a drug treatment that uses chemicals to kill cancer cells. Some targeted drugs are also used for treatment. These drugs may include trastuzumab, ramucirumab, imatinib. Targeted drugs may be used in combination with chemotherapy drugs. Supportive care, which is provided by a team of doctors, nurses, and other trained professionals to help improve the quality of life for people with cancer and their families. Supportive care used with all of the appropriate treatment may help people with cancer feel better and live longer. Thank you for watching our video.
Okay, so let's look in our textbook. So, as we mentioned, stomach cancer is prevalent in certain parts of the globe where they eat more pickled, smoked, and salty foods. So, Asia, Eastern Europe, and some other parts. Also, in people who have genetic predisposition for it, especially if it's from both families, then there's a very good chance they may end up with some malignancy in the stomach. Question is just when. Unfortunate H. pylori, Helicobacter pylori bacteria, if not treated properly, can eventually lead to ulceration and the cancer in the stomach wall. So early screenings, endoscopy, barium enema may help in addition of symptoms. Most of the people report some mild symptoms such as distension, belching, discomfort after eating, acid regurgitation, and then moderate signs, so pain in the abdominal region, poor appetite, lack of strength, and then more severe one, loss of weight, blood in the stool, vomiting the blood, and so on. And so often peptic ulcers needs to be ruled out, that they're not the cause of this versus the malignancy. Because peptic ulcers may cause most of these symptoms themselves. Unfortunately, unresolved peptic ulcers may eventually lead to malignancy in the stomach. So often, metastasis of the stomach cancer means they'll spread to liver, nearby organs like a spleen, pancreas, intestines, and so on. And so after that, it usually spreads to brain and the bones. Dietary irregularities play a huge role. Again, bacteria such as wind cold, so H. pylori may contribute to the future generations of the cancer. So is the other symptoms like phlegm, damp, emotional, unresolved emotions, like people who are introverts, they literally swallow their emotions. That leads to them being stuck in certain emotional states, which means that hormones are constantly circulating in their blood and liver is having a hard time removing neuropeptides or hormones, or what we call Tianhui, heavenly dew, right? And that leads to liver eventually failing to purify the blood to proper pH, and that blood is shared with the stomach, spleen, and pancreas, and adversely affects the stomach. The stomach uses plasma from the blood to create hydrochloric acid, and some other portions of the blood to create surfactant coating that lines the stomach and other substances. So adverse reaction with the liver and emotional state can lead to eventually malignancy in the stomach. So let's look at some of the treatments. So we're going to look at internal treatments. So liver and stomach disharmony, also known sometimes as a liver insulting or invading the stomach. So we have distension, we have fullness, intermittent pain in the stomach, maybe running to chest and ribs, hiccups, vomiting, nausea, belching, acid reflux. Tongue is often pale. It's thin with thin white or yellow coating. Pulse is wiry or thready. So we have to reset the relationship between the liver and the stomach. We have to make sure the stomach chi moves downward and reduce the pain. So here they're using couple sort of, so two formulas, and one is enhanced. So they use Xiaoyaosan, Free Wonder of Bupleurum and Dang Wei, that is combined with inula and hematite decoction. So the second formula, so that's Chuan Fu Dai Tang. And then there's a third formula, Shu Gang Wan Jie Jian. So that's the soothing the liver pill with modification. So soothing the liver and Xiaoyaosan are basically liver-based formulas. Xiaoyaosan resolves the relationship between liver and the stomach and spleen. Shu Gang Wan deals with resetting liver itself. And inula and hematite decoction works to stabilize again a relationship between both. So we have Eugene, so curcuma, chuchao, chai, bupleurum, which is stir fried with the vinegar, zhe xiangfu, Chenpi, they're all there to reset liver qi and relieve liver qi depression. Chao Zhike, Aurantis, Ginage, Muxiang, Oklandia, they all regulate stomach qi to disperse stagnation and transform accumulation based in the stomach. Bai Shao, White Peony calms the liver yang. Baijiu, Fuling, basically drain dampness and fortify spleen, but also produce some diuresis, the urination. Shuangfu Hua, Inula, Daijiu, Hematitum, Chixiang, Qingbai, Banxia, basically reset the flow of stomach qi downward, preventing vomiting, nausea, belching, and they also thin down possible phlegm. So Yanhu So Cordialis, Chuan Lianzi, Melia, invigorate the blood, and they're known as the painkillers as well, right? Bai, Banjalia, Scutaria, they're anti-inflammatory and antitoxic. They also suppress malignant cell replications. The next pattern we're looking is spleen and stomach qi deficiency with the cold in the background, right? So we have dull pain in the stomach that it's made better by warmth and pressure. Morning intake of food is often vomited later in the day or night. Food eaten at night is vomited usually 6 to 8 hours later in the morning. So basically food just sits in the stomach, it's not properly digested. There's no churning effect. And eventually it's ejected. And the food that remains is poorly absorbed in in duodenal part of small intestine. Person may vomit clear water, or sometimes acid. They present with this pale kind of deconditioned look with cold limbs. They're often very withdrawn physically and mentally. There's some edema, maybe in face and extremities. Often morning diarrhea or loose stools through the day. Tongue is pale and large with teeth marks, white and moist coating. Pulse is deep and moderate, sometimes thready or soggy. So treatment principle here is to warm the middle burner, dissipate the cold, fortify spleen and stomach at the qi level. So they're using here two formulas: the decoction for regulating middle burner, combined with 6 gentlemen decoction. So Li Zong Tang, Liu Juzhen Tang, Jiejian with modifications. So we have qi tonics in first group. So that's ginseng, renshen, dangshen, Codonopsis, Huang Qi, astragalus. Then we have Baijiu, Fuling, and stir-fried yiren, so Chao yiren, basically to promote removal of dampness and boosting spleen transformation, transportation functions. Ganjiang, so ginger, rogui, cinnamon, Evodia bujuyu, Hongdu Guo Fan Banxia, prepared Pinelia, Dingxiang. They basically warm and reset middle jiao, dissipating cold, transforming phlegm, and stopping the vomiting. Tuzi, Cuscuta warms and supplements the kidneys as an anchoring organ. Tangxiang, Moziqi alleviates the pain. Jiao Shenjia, Jiao Shenchi, Jiao Maiya, Qianpi, they're all used to reset stomach digestive functions. Long Wei clears the heat, resets the toxicity, and again stops the cancer from multiplying. Next pattern that we have enduring stomach heat, damaging stomach yin. So that means there's ongoing inflammatory changes in the stomach, often due to hyperacidity of hydrochloric acid or stomach acid. So which basically works through surfactant coating that lines the stomach. So we have a sensation of burning, heat in the stomach, dull pain, discomfort in the stomach region, belching. Person does not have desire to eat despite that they're hungry. There's acute pain after food intake, dry mouth, and person prefers cold drinks. There's sensation of heat in the chest, palms, and the soles, and there's some constipation going on as well. Tongue body is deep, often red, dark red, has cracks and almost no coating. Pulse is steady and rapid, slippery, and surging or rapid. So treatment principle is to boost the stomach functions, nourish the stomach yin, clear the inflammatory heat in the stomach, and relieve toxicity. So here we have again two formulas. So we have Yi Wei Tong combined with Mai Men Dong Tang Jiejian. So the decoction for boosting the stomach is combined with a yin tonic formula. So we have yin nourishing, moisturizing herbs and cooling herbs. So we have the gypsum, shigao, huanglian, coptitis, anamaria, jimu, to drain the stomach fire, so reset stomach acidity and protect the body fluids. Beisha Shen, Mai Mendong, Yuzhi, Shihu, Tian Huafen all nourish the yin of the stomach and generate body fluids. Chen Pi, Fa Banxia, Juru are acting to thin the phlegm and in anti-inflammatory way. Also, they're redirecting stomach qi downward. Da Huang Manxiao, Mudan Pi, Chao Zhizi, they clear the heat. They also promote purgation. So basically, they purge the person. Chao Maiya, rice, gene aging, transform food accumulation and promote appetite by regulating the bile secretion. Phlegm cold congealing in the stomach is the next syndrome. So we have chest oppression, fullness below the diaphragm and below the heart, often problems with swallowing, vomiting of phlegm and saliva, blunt taste in the mouth, a reduced food intake because of that sense of vomiting, distension in abdominal region, phlegm nodules, often in the neck, obesity due to deficiency of the stomach, so they retain the fluids, yellow facial complexion, loose stools. So tongue is pale red with white, often thick yellow or greasy coating. Pulse is wiry and slippery. So treatment principle is to fortify spleen, dry the dampness, transform or thin the phlegm into dampness, and then deal with it and dissipate any possible lumps. So we're using Urchin Tang combined with Hai Zao Yu Tang Jiejian. So to mature ingredients, Urchin Tang is known phlegm thinning decoction. And then Sargassum Jade Fuzz decoction is the one that deals with often spleen and stomach yang deficiency, but also with hypothyroid conditions. So we have several groups of herbs. Taizi Shen supplements qi and generates body fluids. Zhangzhi, Baizhi, Yi Ren act as diuretics, fortifying at the same time spleen qi. Lai Fuzi, Chen Pi promotes movement of the qi and transform accumulation of the fluids. Qing Banxia, Pinelia Gualo, dry the dampness, transform the thin the phlegm, and disperse the focal distension in the middle jiao. Hai Zhao, Jiangzan, Kunbu soften the hardness and disperse the swelling with so-called saltiness. So basically, herbs contain here more iodide, and they work by softening the masses, and there may be malignant. Shanzegu, clearly heat relieves toxicity and stops malignant cells from replicating. Hematidum Daiji, Shi Zhuru, resets the stomach qi downward and stops the vomiting. Depletion of qi and blood affecting the stomach is the next pattern. So we have generalized lack of strength, feeling flustered, with shortness of breath, dizziness, sallow yellow, lustrous facial complexion, pale lips. Often irritability is due to a lack of anchoring due to deficiency. In the middle of jiao, sleeplessness, spontaneous sweating, night sweating, low-grade fever. Sometimes face may be puffy, so there's facial edema. Reduced food intake. Often they report bland taste and they can't taste the food. And then in the background, there may be deficiency of kidney, yin and yang. Tongue body is often pale. It's swollen with greasy coating, pulses deep, tready, and forceless. Treatment here is to boost and supplement the stomach qi, nourish the blood, fortify spleen, but also augment the root organs, the kidney, and either yin or yang depth. So we have here Shikuang Dabu Tang Jiejian, perfect major sublimation, decoction modification. So this is a formula that it's made out of the Bajian Tang, the 8 substance decoction. It's a qi and blood tonic, and they added extra, usually 2 herbs to make it to Shikuang Dabu Tang. But here they added more herbs on top of that, in part to deal with additional pathologies. So we have Huang Qi, Dang Shen, Huang Jing to supplement the qi in the first group of herbs. We have Baizhi, we have Fuling as a diuretics to dry the dampness and tonify the spleen. We have Dang Wei, Dang Shen, Shen Di Huang, Shu Di Huang, Yi Jiao, Gu Jizhi, Bai Shao to boost the qi and nourish the blood. We have Tusazi, Kuskuda, Placenta, Zhehe, Rogui, cinnamon to boost the kidneys and consolidate essence and warm the kidney yang. Chenpi and Chao Maya are used here to promote movement of qi and disperse any accumulation of stomach. Acupuncture, of course, can be used here very effectively as well, and in addition with the herbs. So general points are a combination of backshu points and some local points as well. So main points are frontal point of the stomach, zone 1, so CV or REM 12. Bladder 17, bladder 21, backshu points are used here, with often bladder 20. So for stomach and spleen and diaphragm. Stomach 36 is used to basically balance the middle jiao. PC6 is used for vomiting. Large intestine 4 and spleen 6 are used to regulate the dispersion of dampness. So acupuncture should be done daily if possible to complement the herbal treatment as well. So we also have proprietary hospital formulas. They're used to treat usually cluster of the symptoms as a complication of stomach cancer. Nausea and vomiting, dry mouth, pain, constipation, vomiting blood in the stool are all common conditions. So For abdominal distension, there's here a set of herbs that we may use. For diarrhea, we have another set of herbs. Anemia often are treated with iron-rich herbs and blood tonics. We also, here in the West, as we mentioned before, we see patients post-surgically. And so in post-surgical stage, we focus on regulating spleen and stomach and boosting the middle jiao. So liver stomach disharmony, where we dredge the liver, fortify spleen, harmonize the stomach, is something we would treat post-surgically. And again, there's a number of proprietary herbal formulas we may use. Second pattern is the one of the stomach qi and yin deficiency. We're trying to boost the stomach digestion, but at the same time rehydrate the stomach region as well, and trigger more lymphatic drainage by reducing toxicity around. Acupuncture, again, can be effectively used for a number of chief complaints. So stomach pain, for example, post-surgically can be treated by points like backshoe points like bladder 20, bladder 21 for stomach and spleen, stomach 36, frontal point, CV12, liver 13 for spleen as well. And if there's a hyperacidity, we can add kidney 3 tai chi. So distension and fullness of the stomach can be also treated with acupuncture to fortify spleen, post-surgically harmonize middle, burner, and benefit movement of the fluids. So bladder 20, liver 13, spleen 9 can fortify spleen, drain the dampness, and support the middle jiao. Bladder 21, front mu and CV12 backshoe point of the stomach can be used to reset middle jiao, dissipate cold, and boost stomach qi. So moxa can be used as well sometimes, especially on the front around Ren or CV points. So Ren 6, Ren 8 with the moxa pole, Ren 12, and so on. Ear acupuncture is also used throughout treatments in oncology. So here we have spleen, stomach, shenmen, subcortex, with either tack needles like Pionix or with the Bakari seeds. And generally, here they say that we change seeds every 3 days using alternate ear. When we use needles, we use both ears, and we don't change the needles for 7 days unless they're bothering the patient. So distension, fullness of the stomach, we have points like spleen, lung, sympathetic nerve, endocrine, and subcortex. During the limited radiation treatments that targets the stomach region, there's a number of toxicity that builds in part, and dermatitis that often overlaps the top of the skin where they do external beam radiation. So nutritionally and herbally, we try to address dermatitis and decrease lymphatic drainage, as well as increasing toxicity. Chemo is often given when there is no way to operate on it, to try to suppress the growth of the tumors and cancer. And again, chemo is a very heavy therapy, produces lots of side effects. So it may induce things like reduced appetite. So here they're using Xiangsha, Luzhen tongue, so Clondia and ammonium 6 gentleman decoction. Xiaoyaosan may be used for distension, migratory repair in the stomach. Jupi, Ju tongue, tangerine bamboo shaving is used for nausea and vomiting caused by stomach heat. Vomiting clear cold liquids from stomach cold is treated with Dingxiang Shidixan, clove and persimmon, calyx powder. Diarrhea can be treated with Shenling, Baijiu, ginseng, Korean white chocolates powder. Weakness in constitution affecting qi and blood can be treated with number of qi and blood tonic herbs, or sometimes with something like Bajan tongue. Bone marrow suppression is often treated with a number of the qi and blood tonics as well. So let's look at some other treatments post-surgically or post-chemo radiation. So liver and spleen disharmony, or liver basically invading the spleen, is another syndrome we see in the stomach cancer. So a bitter taste in the mouth, dry throat, distension, pain, hypochondrium, fullness and distension in the stomach, poor appetite with acid reflux, tongue is red with yellow, greasy coating, pulse is wiry and slippery. Treatment principle is regulate liver and harmonize the spleen. So we use the Shao-San with modifications. Spleen and stomach disharmony with mental and physical fatigue, fullness and distension in the stomach and abdominal region, reduced appetite, retching, nausea, vomiting, and loose stools. Tongue is often red with thin and white coating or greasy coating. Pulse is deep and tready or slippery. So treatment principle is to fortify spleen and harmonize the stomach. So Shenling Baijiu, Jiejian, ginseng, Korean white chocolate is powder with modifications used to reset the two organs in the middle jaw. Heart, blood, and spleen qi deficiency with main symptoms of feeling flustered, shortness of breath, general lack of strength, insomnia, profuse dreaming, poor appetite, loose stools, tongue that is pale with a thin white or yellow coating, pulse that's deep, tready, and forceless, is treated through supplementing heart, blood, and augmenting spleen qi. And we have ginseng and longan decoction, or also known as spleen returning decoction, gui pi tang jiejian. Spleen and kidney yang deficiency, or sometimes kidney yin deficiency, whereas spleen yang, kidney yin deficiency, with main symptoms such as dizziness, tinnitus, insomnia, profuse dreaming, pain in the back and lower back, abdominal distension, poor appetite, facial swelling, loose stools, tongue is pale red with white or thin yellow coating, pulse is tready and rapid. So treatment principle is to supplement kidney at the yin level, augmenting spleen at the yang level. So we may use 4-gentleman decoction combined with the remaining 6 decoctions. So 4 君子汤和6味地黄汤接jian. So generally, by the time they discover carcinoma, they will go in with the surgery, and usually at stage 1, stage 2. Stage 3, it's already too complicated, spread it too much around. They may attempt surgery, sometimes they don't, they go with chemo, and maybe targeted radiation and targeted hormonal therapy. So herbs and acupuncture are used to reduce major side effects, help the lymphatics to drain better, and boost overall Zheng Qi. Nutritional or dietary therapy, Shi Liao, can be used, but the problem sometimes is holding the food, because the organ in question is actually organ who has to digest, so it's the stomach. So this is often there are 2 ways to address this. One is if you have in TCM hospitals, they IV basically nutrients through veins, right? Intravenous route. And the second one is to cook the food for a long time in crock pots and pressure cookers, and then turn it into basically a fluid that is sipped slowly so a person doesn't vomit it. Qigong therapy can be used. It can be very beneficial if patient has strength and interest. Ear acupuncture, as we mentioned, can be used. So there are a number of therapies that we can use on top of the acupuncture and herbal pharmacotherapy. So at this point, we're going to look into another presentation that we have about stomach cancer. And I'll just add this into your chat here if I already didn't. Let me see. I did. Yeah, okay. So let's have a look at this presentation.
Good morning, everybody. Welcome to another episode of Surgery Live. Thanks for being here. And with that, I'll turn it over to Dr. Rob Simon to introduce Dr. Joyce and our topic for today.
Hello, good morning, everybody. Dr. Joyce did his residency at Cleveland Clinic. He then went on to Roswell Park in Buffalo, New York to complete his surgical oncology fellowship training. And we are happy to welcome him back as the newest member of the HPB team. And today he's going to be talking about gastric cancer. So please feel free to chime in and ask questions and take it away, Dan.
Good morning, everyone. Thank you for the introduction, Rob. So I'd like to talk a little bit about gastric cancer today. And in many ways, it's a little potpourri of topics. I think topics that are frequently ignored. I think as a surgical community, we have beaten the lymph node dissection and some technical issues to death. And I think there's actually some more important things and topics that we encounter more frequently. So I'll give a very brief overview of the care path for resectable gastric cancer, but that's widely available in the guidelines. I want to talk a little bit about what surgeons should know about the molecular classification of gastric cancer. I think in the case of gastric cancer in 2020, we're treating it like we treated breast cancer in the 1970s. No one would even dream in 2020 of treating a breast cancer without knowing its hormone receptor profile, its HER2 status. And as of today, in our national guidelines, we do not recommend any subclassification of gastric cancer. We treat it all the same. And I'll show you a little bit of data to show that we're probably not doing the right thing in certain cases, and we're using very broad brushstrokes to treat what is a very heterogeneous disease. Then I think something that we all encounter is how do we palliate patients with advanced gastric cancer? Certainly in my practice, the majority of patients that turn up to my clinic typically have stage 4 disease. And I think as surgeons, we can also help those patients, and we can help drive the discussion of how they should be managed. There are many tools in the toolkit for managing things such as bleeding and obstruction, and I don't think any one size fits all. And I think looking after those patients is just as important as knowing the technical details of a D2 lymphadenectomy. So actually, in the United States, gastric cancer is an orphan disease. It's decreasing in incidence, and particularly the intestinal type, those distal gastric cancers that one would have seen in the past, mainly due to improved sanitation, the diagnosis and treatment of Helicobacter pylori. Proximal gastric cancers are actually on the increase, and depending on your institution, you may see more or less of those. If you've got a strong thoracic surgery group, you may not see much of them at all, and a lot of those patients fall into different treatment paradigms based on people's training pathway. But I think there's some, it's important to have involvement of surgeons that are both comfortable in the chest and in the abdomen. Across the world, gastric cancer is the third leading cause of death, in the Far East, but in the United States, it's number 15. So even at high volume centers in the United States, we just don't see very much of gastric cancer anymore. So I think that's why, some of these topics get a little bit ignored. And I think it's important that these cancers are treated in centers with a reasonable level of volume, which again, in the United States may not be that much. It could be 15 or 20 resectable cases a year. There are some genetic considerations, the CDH1 mutation, hereditary diffuse gastric cancer. We tend to see a fair amount of that here at Cleveland Clinic. And just for any residents that are on the line, And that's, when you take a history of those patients, often you'll find that there's a history of lobular breast cancer in the family. And that's something, when you're seeing a patient with gastric cancer, was there breast cancer in the family? And if it was there lobular? And you need to start thinking genetic reasons in your head. Patients with Lynch syndrome certainly develop gastric cancer. We have a lot of patients under surveillance here in the Weiss Center for the hereditary colorectal neoplasm. So again, we see a fair amount of those. And then in familial adenomatous polyposis, typically as foregut surgeons, we're focused in on the duodenum, but certainly in the past 10 years or so, our GI colleagues here at Cleveland Clinic have described a striking increase in the incidence of gastric cancer in these FAP patients. And whether it's that we're finding them, they're living longer and developing it, or the phenotype is changing, I don't know. But certainly one needs to keep an eye on the stomach in these patients. And in particular, they tend to get this carpeting of fundic gland polyps, and it may take EUS to uncover those cancers. A lot of those cancers, when they present, have been at very late stages, despite that they've been undergoing endoscopic surveillance of their duodenum. So you have to think about gastric cancer in that population as well. So very briefly, how do we manage a patient with resectable gastric cancer? So obviously, like any cancer patient, they have to be staged. Particularly in the early cancers, endoscopic ultrasound is key. And T1A cancers can be treated with endoscopic resection. They do not need a gastrectomy. And if you find deeper disease or high-risk features, those patients can go on to receive surgery. But obviously, you need an endoscopist with the skill set to do that. T1B cancers need formal resection. And then when you reach the population of T2 or patients with positive nodes, essentially those patients should receive perioperative chemotherapy. I'll discuss later on about some caveats to that. T2 disease, when our staging is not perfect. So if you have a patient with the T2 N0 clinical stage, 25-30% of those will have, higher stage disease. So that's why we book or lump those patients into the perioperative chemotherapy protocols. If at all possible in a patient whom you're going to do perioperative chemotherapy, you really should consider a diagnostic laparoscopy, particularly for the thicker tumors, the T3 to T4s. Even if they don't have obvious peritoneal mets, 10% of those T3, T4 tumors will have positive peritoneal cytology, and their outcome is equivalent to gross peritoneal disease. I don't even want to begin to discuss the role of cytoreductive surgery in HIPEC and gastric cancer, because really there is no role outside of a well-defined clinical trial. But I think it's important to stage these patients appropriately. Certainly chemotherapy can so-called clear the peritoneum when you have positive peritoneal cytology. Whether that actually has a difference on their overall outcome is unknown. So I think you need to be laparoscoping these patients up front. It's always hard to fit them into the schedule, but I think it's a worthwhile endeavor before you put a patient on a potentially curative pathway. One thing that I notice a lot is when patients come to my clinic with gastric cancer is they come with a staging PET scan. I honestly use PET relatively rarely in gastric cancer. In those diffuse lesions, those lesions with signet ring cells, mucinous tumors, the PETs are frequently negative. I'll show you a picture on the next slide of a patient that clearly has Linitis plastica and the PET is completely quiet. So I think it can be useful if you have a directed question based on a high quality contrast enhanced CAT scan. But to me, a PET scan for gastric cancer is limited. I think a good quality cross-sectional contrast enhanced CT scan is much better. If you have questions based on the anatomy of a particular node on a CT scan, I think that's a useful use of PET scan. But to me, an isolated PET scan does not adequately stage a patient with gastric cancer. And I do see that coming through the clinics. And in, the standard of care, I would say in this country, and for many years before this, for local regionally advanced gastric cancer is the perioperative chemotherapy approach. Historically, in the United States, we did use adjuvant radiation, but a relatively limited role for that in the era of D2 nodal dissection. But certainly there is evidence for it in the adjuvant setting if you operate on a patient up front. So this is an example, just of a PET scan where you can see this really impressive thickening of the stomach. And in fact, when we got a proper CT, this patient had peritoneal carcinomatosis, and the PET scan is completely quiet. And some oncologists are in tune with that, but often when these patients come through tumor board, you get this false sense of reassurance if someone has just read the PET scan report. So I think the multidisciplinary evaluation and deciding on the clinical staging is absolutely key. As surgeons, sometimes we're a little bit slow to get patients on the schedule, and I think the oncologists give up on us and sometimes just start patients on systemic therapy, maybe even without a surgical referral. So I think we've got to make ourselves available. We've got to be involved in that initial allocation of the clinical stage. So just a few words on ESD for superficial gastric cancer. Historically, this was really described in Japan and Korea, where they actually have screening programs for gastric cancer due to their risk profile. And they, for many years, have shown good results for endoscopic therapy of early gastric cancers. But now there's been a large cohort published out of the United States, and this included patients from Cleveland Clinic led by Dr. Bott. And this is very safe for T1A gastric cancers. If you want to be absolutely restrictive with your criteria, they should be T1A tumors less than 2 centimeters, non-ulcerated, no lymphovascular invasion, and really well-differentiated tumors. There are, of course, expanded criteria for this. Again, I think you have to take the condition of the patient into account. If you have a patient maybe with an ulcerated tumor that's young, long life expectancy, I would take that patient to the operating room. But if you have an 87-year-old patient in a nursing home, I would expand your endoscopic options. The R0 rate, 75% or even higher, depending on how you choose these patients. There's a very low complication rate, about a 6% intraprocedural perforation rate. Vast majority of those can be managed endoscopically. I think the way we manage these patients here, these patients see everyone up front. They see the surgeon, the oncologist, the gastroenterologist. So it's a team discussion so that we can deal with positive margins afterwards, so that we can make a good assessment of whether they've got nodal involvement and that we can adequately clinically stage these patients. So again, one of the key points being we've got to get that clinical stage as accurate as we can up front. So just very briefly, since I mentioned peritoneal cytology and diagnostic laparoscopy, I just wanted to briefly touch on that point. So the standard of care for patients with peritoneal metastasis, that's M1 disease, whether it's gross disease or just positive cytology. The standard of care is chemotherapy with palliative intent, of course, using an operation or other techniques to palliate the patient if necessary. The outcome for positive cytology without peritoneal disease is really equivalent to gross peritoneal disease. So for standard of care, I would not treat it any different. When it has been studied, neoadjuvant systemic chemo can convert positive peritoneal cytology to negative cytology. Prognostic indications are really unknown. So, what do you do with that patient? So if they're elderly, poor performance status, I think best supportive care, see what therapy they will tolerate. But, if you have a young patient that converts, that has tolerated treatment well, that has demonstrated a response, I don't think it's out of the question to pursue a resection. I would only do that after maximizing their preoperative chemotherapy. So, the FLOT data, what I'll talk about in a moment, that you talk about 4 cycles pre-op, 4 post-op, would try and push that patient to get more systemic therapy on board. Those patients really need to prove their biology. Cytoreductive surgery and HIPEC, that's a whole talk in itself. I don't know, to tell you the truth. There's some trials going on in the Netherlands and France looking at it in gastric cancer. There was one trial out of China that looked at it that was positive, but really it's in very, very, very selected circumstances, particularly for something like a total gastrectomy. it's a lot to add to cytoreductive surgery and HIPEC. But you will occasionally find those patients that have had a good response, that have made it through a lot of systemic treatment, and an operation could be an endpoint to systemic therapy. So it's not out of the question, but a little bit beyond of what we talk about today. So in terms of, for years, we've used the Loren classification to classify gastric cancer. And then on the right-hand side of that little table, there's the World Health Organization classification, which, puts you right to sleep. I've never found these particularly useful. I think they've been of academic interest. They don't particularly change how you manage the patient. Perhaps in the diffuse type, you might take a wider margin or something, but really inconsequential to me as a surgeon. So let's move to the next slide.
For the glory of sports, be ready with high protein from Vector.
So I know it's early in the morning, and I'm not going to go on too much about, molecular classification, but I think this is the TCGA molecular classification of gastric cancer. I think this, with potentially some tweaks, will be the game changer in how we approach and treat gastric cancer. To me, this is the equivalent of hormone receptor status in breast cancer. So this was looking at, I think, almost 300 flash frozen specimens of gastric cancer, and they'd done extensive genomic workup. And they classified gastric cancer into 4 distinct types. Chromosomal instability, they typically have intestinal histology, a lot of them focused at the G junction. An EBV phenotype, about 9% of gastric cancer. In particular, these tumors have a lot of immune cell signaling. They've got a lot of a lymphocytic infiltrate. They almost look like a lymphoma under the microscope. And I think going forward, we'll start using immunotherapy much more in these tumors. Very, very, very warm from an immunological standpoint. Then genomically stable, that's the diffuse histology, those patients that have CDH1 mutations. Most importantly is the MSI high standpoint, and that's the group that I'm going to focus on today. So these patients, like colon cancer, you can just do basic immunohistochemistry. And in this group, about 22% of patients were MSI high. In other groups, it's probably closer to 10 to 15%. But this is a real group of patients. And to me, as a surgeon, I want to know whether these patients are MSI high when I see them in my office before deciding on a treatment pathway. The majority of patients with MSI high gastric cancer are just sporadic mutations. They tend to be, you'll see it'll be a MLH1 that won't be expressed, and it's usually due to hypermethylation. I'll come back to the MSI high patients. So for our local regionally advanced patients, the standard of care is perioperative chemotherapy. The ECF regimen was the mainstay for many years, based out of the Medical Research Council trial out of the United Kingdom, or the MAGIC trial. FLOT is now the gold standard, but it's not for everyone, as I will show you. And a lot of the patients that we see, the older patients with poor performance status, I think FOLFOX is a very good option for those patients. So this paper is from 2006, and this was the MAGIC trial, which showed that perioperative chemotherapy had an overall survival benefit for tumors T2 and above. This included G junction tumors and distal gastric cancers as well. And for many years, this was our standard of care. Subsequently, epirubicin was really shown to be absolutely useless and didn't add anything to the situation. But certainly an overall survival benefit, 36 versus 23%. But obviously, it's still very poor outcome. We're still, losing a lot of patients with relatively early disease. In more recent times, we've started using FLOT. It was a trial led from Germany. This compared ECF versus FLOT. There was a 15% complete pathological response, so certainly a more active regimen. This regimen is not for everyone. A quarter of patients are hospitalized for toxicity. Half of the patients develop grade 3 and grade 4 neutropenia, 20% with infections. And in this group of patients, less than 50% complete their planned chemotherapy. Most patients get through the preoperative treatment, but a lot do not get their treatment afterwards. So I think going forward, we're all, a little bit like we do in pancreatic cancer or in the rectal cancer world. The real question is can we push more systemic therapy up front? Obviously, you don't want to push it to the point that the patient is no longer a candidate for an operation, but most of these patients do not get treatment after surgery. FLOT data, there was no data on MSI high status, which I'll come back to in a moment, which I think is worth pointing out. So if you've got a patient with a good performance status, I think FLOT is for sure the way to go, but it really is not for everyone. The 80-year-old with gastric cancer that you think will tolerate some chemotherapy, I think FOLFOX is a very reasonable regimen in that type of a patient. So let's talk a little bit about the role of chemotherapy in mismatch repair deficient gastric cancer. So this study was out of Asia, where they do a lot more upfront operations, and they studied the use of adjuvant CAPOX in resected stage 2 and stage 3 gastric cancer. And certainly in the group as a whole, it's beneficial. So CAPOX is a good option if you operate on a patient up front and they've got positive nodes. But when they broke it down by MSI high status, no benefit for patients with microsatellite instability. So out of that group of patients, it didn't work, the chemotherapy, period. Then what about the patients that we see where in the Western world we tend to do a lot more perioperative chemotherapy? So data relatively limited. This is from the MAGIC trial where they used the ECF regimen. They had 20 patients with MSI high status. There was no significant pathologic response to chemotherapy in any MSI high patient. And in fact, when you look at the Kaplan-Meier curves here, you can see that chemotherapy may actually have been detrimental in this group. And there's been a lot more looked at this in the colon cancer literature. But 5-FU may not be the right thing for these patients. Also, cisplatin is probably not effective in the MMR deficient group. Limitations of this data is that really ECF has been superseded by FLOT. We don't have any data based on those patients' MSI high status. Oxaliplatin, based on the colon cancer literature, may have some activity in these patients, and taxanes don't have the same limitations in terms of microsatellite instability. So whether we can apply this to the FLOT data, it's questionable, but I think this really raises questions about the use of chemotherapy in these patients. Next slide. So this is a meta-analysis that used the MAGIC data, the classic data, and again, pretty compelling, evidence to show that chemotherapy didn't add anything to these MSI high patients. So how do we put this into practice? This is, in full disclosure, this is not on the guidelines, but I routinely order MSI status on endoscopic biopsies. I think if you have a patient with clinical stage T2N0 disease, that patient definitely gets an operation up front if they're MSI high. I think that's very reasonable. It's not on the guidelines, but I really don't think that there's any reason to give them chemotherapy that, number one, is not effective, and number two, could be harmful. For more advanced disease, I think it's reasonable to consider FLOT. But again, it's, these patients overall, when you look at them, do better with surgery alone. So if you have a patient with poor performance status, maybe that's more on the symptomatic side of things. With MSI high disease, there's nothing wrong with doing an operation up front, and I think we'll find more data to support that. I'm a great believer in clinical trials, but you really have to question whether the trials that we have for perioperative chemotherapy apply to these patients when you really delve down into it. So I think, you have to have a good tumor board discussion. So just in terms of palliating gastric cancer, we see a lot of patients with bleeding. Certainly that can be an argument for an upfront operation. Radiation is fantastic at bleeding. Even a single 8-gray dose often gets you fantastic hemostasis. The response is durable, about 3/4 still of hemostasis at 6 months. And I don't think you have, if you want to get a patient some preoperative treatment, if they're bleeding, a single dose of radiation may allow you to get them to preoperative chemotherapy if it's indicated, taking the biomarkers into account. So just don't forget about radiation in terms of bleeding control. You do not have to race to the operating room. I don't worry about operating, a long time after radiation. I think we worried more about it in the past, but both with, esophagus and rectal cancer might make the operation a little bit more difficult, but it certainly doesn't preclude an operation many weeks to months after radiation. Gastric outlet obstruction, last but not least. We see a lot of these patients. I think you have to consider their life expectancy. It's longer than pancreatic cancer. If you can get some targeted therapy to HER2 or if they're MSI high, think about how long they'll live. A stent may not be durable enough for you. Do they have synchronous bleeding or anemia? That might push you to a palliative resection, which certainly has some morbidity. Think about the extent of disease as well. So just in terms of surgical bypass versus stenting, a question that we as surgeons come across, stents work well, they work quick, but they don't work for long. So we all, struggle with doing these GJs, and I think they take a long time to work, but I think it's worth having the discussion with the patient. If you think they've got a reasonable length of life to live, I think there's still a role for surgical bypass. And finally, palliative gastrectomy. There may be some survival benefit in selected patients. If you have a patient that's bleeding and obstructed, and you think you can do the operation with a reasonable level of morbidity, I think it's a reasonable option. I think you have to think about it. When you do a palliative gastrectomy, you do not need to do an extensive lymph node dissection. So the key takeaways, I think you've got to accurately stage these patients clinically. It's a heterogeneous disease. We're really mooching around in the dark right now with gastric cancer. So I think we need to be attuned to the molecular profile, and I think that will come more and more into play. A minority of patients are cured, so we have to consider palliation. We have a role in that, and radiation is fantastic for bleeding. It really gets you out of trouble. So I'll wrap it up there.
Great talk, Dan. So just to kind of, if anybody has any questions, please enter them in the chat or speak up. But, Dan, can you just talk a little bit about, surgery and if you place feeding tubes in these patients routinely, because a lot of them, even after subtotal gastrectomies or especially total gastrectomies may take them a little while to, tolerate adequate PO intake.
So certainly in our group, there's nothing that incites more hatred and love in equal measures than feeding jejunostomies. After a total gastrectomy and a very, very low threshold for a feeding jejunostomy tube, I think how you place them, the tubes that you use, all of those, tubes have complications, but I certainly have had a good experience with feeding jejunostomy tubes. But I think you have to be careful how you use them. If you have a, distal gastrectomy, I think is different, whether they have gastric outlet obstruction to begin with. But I think you have to be careful with feeding tubes. If you think it's just a shorter level of time, I think a nasoenteric feeding tube can be useful. But if you have an old patient that you do a total gastrectomy on, I think a feeding tube really gets you out of trouble. A lot of the time you can get them home, get them on tube feeds. There's no rush with eating. You can really take your time. So I have a pretty low threshold for a feeding J-tube.
Great. And then a question was posed in the chat about commenting on the treatment options for patients with Lynch after total gastrectomy with a positive proximal margin.
So I think, first of all, if you have a positive proximal margin, I think hopefully you would have done a frozen section in the operating room. Usually I'll do one frozen. If it's positive, then I'll take the rest of what I can. And then, after that, I think you write it off to bad biology. I certainly think in those patients, I would think about, adjuvant chemoradiation. Of course, that's, 5-FU based chemoradiation, not a lot of data. Radiation is tough after a total gastrectomy. You know, the Intergroup 0116 trial that came out of the United States, that, you know, that really we don't use in the same doses because it's pretty toxic. But I think, you know, I would radiate that patient, but you're probably looking at bad biology in that situation, to tell you the truth.
Yeah. And then
I wanted to ask a quick question, if
yeah,
that's
go for
okay.
it. Yeah.
So in the, I guess two questions. One, in the rectal cancer world, you're right, we operate after radiation all the time, but we divert those patients with a loop ileostomy. Do you have any concerns about your anastomotic or any anastomotic concerns, one, after operating radiation? My second question is, in terms of your staging, we've also moved away from endorectal ultrasound, which is how we used to locally stage these, and we now do MRIs. Is there any reason or utility to think about that? Does anyone look about that in gastric cancer? For us, it avoids the, you know, it's not technician dependent. MRIs are pretty readily available, and it lets us see the mesorectal envelope and lymph nodes. Didn't know if any of those would be relatable concerns in the gastric cancer world.
Not so much MR. I think the thing with gastric cancer is we don't have anything quite as good as an MRI scan. So I think it's about using the modalities of contrast enhanced CAT scan, EUS, and PET scan where indicated all together to make a good clinical decision based on all of that. But even with that, we understage people, we overstage people all the time. The radiation question, I think it depends where you're talking about. I mean, if it's a single shot 8 gray, you know, for a distal cancer, I don't really worry about that. For the GE junction stuff, I mean, you know, I didn't go into so much into GE junction, but for GE junction tumors, you know, based on the CROSS trial, you know, people have been doing preoperative chemoradiation all the time. Some retrospective data to show that it may have an impact on your anastomosis, but in the esophageal world, you usually get away with it, to be quite honest with you. Certainly if, you know, depending, you know, if you're, it's more so for esophageal gastrectomy, you might try and minimize the amount of radiation to the gastric conduit. If you maybe have a Sievert type 3 with a lot of fundal involvement, you might push that patient to perioperative chemotherapy to get away from the radiation. But honestly, they usually do just fine.
I would also argue that, you know, in those patients, extremely low threshold to placing a feeding tube intraoperatively, and then, you know, treating, even if they do leak, treating them with stents or intraluminal plastic stents through the hole actually seals them up pretty nicely. Another comment about genetic testing. Is there any role in genetic testing in family members of patients with gastric cancer?
I mean, I think, you know, depending on the age group, so young patients with a family history of lobular breast cancer, I think those patients should have a genetic referral. But, you know, an 85-year-old with a distal gastric cancer, I don't think it's, you know, it's not like pancreatic cancer where we have data per se to drive clinical decision-making in the metastatic setting for chemotherapy. But definitely in younger patients, those patients should certainly have consideration for testing for sure, particularly the diffuse type histology where you might be concerned for CDH1 mutations.
Dr. Augustine, I see that you asked a question about a 45-year-old patient with distal gastric cancer, limited peritoneal disease from a previous diagnostic laparoscopy, upper abdominal, anterior to the stomach, and excellent response to FLOT. Would you proceed with definitive surgery or not?
So that's an interesting scenario. So I think, first of all, if that patient's had a response to FLOT, give them more, finish out their treatment. Then, so the question is that, so there's a few things, you know, the MD Anderson group have shown data about actually trying to clear the peritoneum with laparoscopic hypec and cytoreduction. And then if you clear the peritoneum with up to 5 rounds of lap cytoreduction and hypec, then doing a definitive gastrectomy, you're really trying to, you know, aggressively treat or to help them define their biology. But and that may be an overkill. But the other thing, if that patient will say finished all 8 cycles of FLOT and has good performance status, the patient is up for an operation, I don't think it's wrong to operate on that patient without HIPEC either. The HIPEC thing may just not be helpful, but if that patient has proven their biology, it's not wrong. I mean, we do Whipples for pancreatic cancer. So, you know, and we all have patients that you get a CTP study and they have liver metastases. So while it's pushing the envelope a little bit, it's not completely crazy. You know, I think in some of these patients, an operation can be an endpoint to chemo. I think in these patients, you know, it's often a discussion with the oncologist. If I do an operation, render them NED, you know, can we give them some time off chemo? It's a little bit about quality of life. You know, stringing someone out on systemic therapy until they have unacceptable toxicity is not a great, you know, quality of life either. I mean, the issue is we don't know. It's slightly crazy, but it's not wrong.
Yeah, I sort of second that. I think some of these decisions are based off of, you know, what you're getting to start with. A 45-year-old who clears the peritoneal disease on a subsequent diagnostic lab and completes the entire FLOT treatment. I mean, I personally feel that the data would not basically have that kind of a patient in any of the trials. And if you look at the 15% complete pathological response for the FLOT group, I don't know why one shouldn't try. I mean, we operate for far less indications.
And the other thing in those patients, there's nothing wrong with dragging your feet. So, you know, if that patient completes all their FLOT, you know, I wouldn't race them to the operating room in a month. Even give it 6, even 8 weeks. Let them prove their biology. If they have, you know, if they have recurred after 8 weeks or so again, you clearly are not going to help them. So you know, there's a huge emphasis on time to treat and things like that, but also time can be very helpful. So, you know, dragging your feet a little bit, I think in these cases can be helpful as well, because if you have, you know, regrowth of disease within 8 weeks off treatment, clearly an operation is not going to help. But if they've proven themselves, I think then that's the time to go in and do an operation.
Thank you.
Well, I know it's a little past 7:15, so I guess we should probably wrap this up. But
Okay, so that was a presentation on gastric surgeries, something that we encounter as a practitioner, so TCM and acupuncturist, because patients usually come after gastric surgeries to us for a recovery. So it's good to see what exactly goes into surgical part. So at this point, we're going to take a short break. And when we come back, we're going to look at colorectal cancer. Okay, so we're gonna continue. So we'll look to that liver and stomach cancer, and now we're gonna look at colorectal cancer. Just post video links for us. Okay, so let's look at the first video.
Colon cancer, commonly grouped together with colorectal cancer, is cancer of the large intestine, the final portion of the digestive tract. It is the most common of all gastrointestinal cancers. Colon cancer usually starts from a small growth called a polyp. Polyps are very common, but most polyps do not become cancers. Polyps can be of various types, some of which are more likely to develop into malignant tumors than others. Early-stage colon cancer generally produces no symptoms. Advanced stage symptoms vary, depending on the location of the tumor, and may include changes in bowel habits that persist for weeks, blood and stool, abdominal pain and discomfort, constant feeling that the bowel doesn't empty completely, fatigue, and unexplained weight loss. Early detection is the key to prevent colon cancer. Because a precancerous polyp usually takes years to develop into a malignant tumor, colon cancer can be effectively prevented with regular screening. There are two major types of screening tests. Stool-based tests. Stool samples are examined for signs of cancer, such as blood and mutated DNA. These tests are non-invasive, but less effective and need to be done more often. Visual screening, such as colonoscopy, is more reliable and can be done every 5 or 10 years. Colonoscopy uses a long, flexible tube equipped with a camera and light to view the entire colon. If polyps or abnormal structures are found, surgical tools are passed through the tube to remove polyps or take tissue samples for analysis. Typically, any polyps found in the colon are removed during colonoscopy and examined for precancerous changes, known as dysplasia. If high-grade dysplasia is detected, a follow-up colonoscopy is required to monitor the condition. Colorectal cancers are caused by mutations that increase the rate of cellular division. Some of these mutations can be inherited from parents. Examples of inherited colorectal cancers include familial adenomatous polyposis, or FAP, a condition caused by mutations in the APC gene. The APC protein acts as a tumor suppressor, keeping cells from growing and dividing too fast. Mutations in APC result in uncontrolled cell division, causing hundreds of polyps to grow in the colon. FAP patients usually develop colon cancer by the age of 40. Lynch syndrome, another inherited condition caused by changes in genes that normally help repair DNA damages. A faulty DNA repair results in increased rate of mutations. Patients are at high risks of colorectal cancer, as well as other types of cancers. In most cases, however, the mutations that lead to cancer are acquired during a person's life, rather than being inherited. The early event is usually a mutation in the same APC gene that is responsible for FAP. While FAP is a rare condition, APC mutations are very common in sporadic colorectal cancers. Apart from genetic predisposition, other risk factors for colon cancer include aging, high red meat and low-fiber diets, obesity, alcohol use, smoking, diabetes, and inflammatory intestinal conditions such as ulcerative colitis and Crohn's disease. Thank you for watching. If you like our videos, be sure to check out our new Patreon page.
I'm gonna look at the second video now.
Hi everyone, this lesson is on a high-level overview of colon cancer. So colon cancer is a very, very in-depth, complex topic. We're not going to be able to talk about all the details of colon cancer in this lesson, but we're going to talk about a broad overview of many aspects of colon cancer, including some of the risk factors for getting colon cancer, signs and symptoms, how it's diagnosed, screened, and how it's treated. So let's first begin with what is colon cancer. Colon cancer is also known as colorectal carcinoma or colorectal cancer, CRC for short. It is a cancer involving the large intestine and or rectum. So if we look at this image here, here is the gastrointestinal system. So here's the esophagus going into the stomach, going into the small intestines, which then leads to the large intestine, and then eventually into the rectum, and then that completes the gastrointestinal system. So the large intestine, the large bowel, and the rectum can be affected by this cancer. So cancerous growths can occur in this part of the gastrointestinal system. That is what colon cancer is. So it can be a tumor or growth that may affect the right colon. So the right colon here, we're looking directly on the patient. So this is the right side of the patient. The left colon, so this is the left colon here, or the rectum. So either of or multiple parts of the colon can be affected. And we're going to talk about the pathophysiology of colon cancer, but the brief summary of the pathophysiology is that there is a malignant growth that arises from a polyp. And we'll again talk about this in more depth. Now, colon cancer is a very important topic to talk about because it affects many individuals. And it is actually the third or fourth most common type of cancer. And again, this depends on the country that it is measured in. But likewise, it is a very common type of cancer. Approximately 5% of all cases of colon cancer are actually attributed to two genetic causes. We're going to talk about those in the next slide when we talk about risk factors, but the rest of them are going to be from other factors. Most are going to be sporadic cases, which occur due to lifestyle choices and other factors, and we're going to talk about those in the next upcoming slides. And colon cancer itself is actually the most common cause of large bowel obstruction in adults. So you can imagine that if there's a cancerous growth in the large intestine, if it grows so much, it can actually block off the whole lumen of the large intestine, leading to an obstruction. And this will lead to some other signs and symptoms. We're going to talk about those as well later on in this lesson. And this type of cancer increases in prevalence the older a patient gets. And the actual mean age of onset of this cancer is roughly 70 years of age, but there has been some new evidence showing that the mean age of onset is actually decreasing. So younger and younger patients are actually getting colon cancer. So let's talk about those risk factors now. So we mentioned that older age, so increasing age as a patient gets older, they're at an increased risk for getting colon cancer. And this is common with all types of cancers. As you get older, you accumulate more and more mutations in the DNA, and this is going to increase your risk for getting many different types of cancer, including colorectal cancer. This is going to be more particularly important after the age of 50, but again, as we mentioned before, there has been a lot of new evidence showing that younger and younger patient populations are getting colon cancer. So there does seem to be a lot of lifestyle and other risk factors that are involved in getting colon cancer. A family history of colon cancer is also another risk factor, particularly first-degree family members under the age of 60. So if one of your parents had colorectal cancer before the age of 60, that will definitely increase your risk for also getting colon cancer as well. Another risk factor that is a more personal risk factor for the patient is going to be a history of inflammatory bowel disease. So this can be Crohn's disease, but more specifically, it's going to be ulcerative colitis. So Crohn's disease can increase your risk for getting colorectal cancer, but ulcerative colitis is going to be the more significant increasing risk factor out of the two. So with ulcerative colitis, the rectum and parts of the large intestine are going to be inflamed chronically. And because of that chronic inflammation in the large intestine, it's going to increase the risk of colon cancer. So these last few risk factors have been risk factors that are outside of the control of the patient. But the next ones are going to be important with regards to lifestyle and certain choices a patient can make that can either increase or decrease the risk for colon cancer. One of them is going to be dietary history, especially a low fiber diet. So having a history of a low fiber diet is going to increase your risk for colon cancer. And then a history of excessive eating of processed meats is going to be another risk factor as well. So again, not all meat consumption, but it's going to be processed meats more specifically. So processed meat consumption, pepperoni, salami, those types of foods are going to increase your risk for colon cancer, especially if you eat those a lot. And again, with a low fiber diet, this is going to be a history of a low fiber diet. Now, another important risk factor for many different types of cancers is a history of smoking. So smoking is going to increase the likelihood of mutations occurring in your DNA, and this is going to increase the risk of many different types of cancer, and colorectal cancer is one of them. Another risk factor for colorectal cancer is alcohol consumption. So even small amounts of alcohol consumption can increase your risk for colorectal cancer, but it's going to increase the more you consume alcohol and for longer durations of alcohol consumption. So alcohol consumption increases the risk of colorectal cancer as well. An increased body mass index is also another risk factor. So being overweight or obese is going to increase your risk for colorectal cancer as well. So these are some risk factors that a patient can work on to help reduce the risk of colorectal cancer. And then the last one is going to be the genetic conditions. So this can tie in with family history, but it's going to be more specific to certain genetic conditions we're going to talk about here. So one of them is going to be familial adenomatous polyposis, and another one is Lynch syndrome. These are going to be two very important risk factors, more important genetic conditions that run in the family. These are both autosomal dominant conditions. So if you have this condition, one of your parents must have also had this condition as well. So these two, familial adenomatous polyposis and Lynch syndrome, are going to make up that 5% that we talked about before. 5% of cases of colorectal cancer are caused by these two genetic conditions, familial adenomatous polyposis and Lynch syndrome. Familial adenomatous polyposis is going to be a condition where very, very young individuals, very, very young patients are going to have a increased formation of polyps within their large intestine. Many polyps are going to be formed in the large intestine in these individuals, hundreds to thousands. And by the time they're in their 30s, they can often have cancer. Lynch syndrome is going to be a cancer with a mean age of onset in the 40s. And so it's a little bit later, but Lynch syndrome is also associated with other types of familial cancers as well. We can also see Peutz-Jeghers syndrome being a possible genetic condition that increases the risk of colorectal cancer. And then we can also see Gardner syndrome and Turcot syndrome being conditions that increase the risk for colorectal adenomas or polyps and ultimately increase the risk for colorectal cancer as well.
Melt this sour mineral under your tongue to improve your vision, almost overnight. Did you know poor eyesight isn't just about your eyes? It's about how your brain processes visual information, and our eyes are nothing more than a carrier of that information to the brain. Here's the problem. Prescription glasses and contacts only address the symptoms, not the real root cause. Look, eventually it will get harder and harder to see things around you. Your family might even start wondering if you're able to take care of yourself. And next thing you know, you're being sent off.
Now let's briefly talk about the pathophysiology of colorectal cancer. So we mentioned before that colon cancer arises from colonic polyps. These are adenomas or adenomatous polyps. So the malignant lesion of colorectal carcinoma comes oftentimes from a pre-malignant polyp or a pre-malignant growth. So pre-malignant meaning that it's not malignant yet. It could be malignant if it keeps growing or it continues to exist. So these are going to be important to recognize and remove. And we're going to talk about this when we talk about screening and polypectomies. So adenocarcinomas are going to come from these adenomas or these adenomatous polyps, and they're going to represent the majority of cases of colorectal cancer. So adenocarcinomas are going to be the majority of cases. They're going to be endoluminal adenocarcinomas, which means that they're going to be within the lumen, within the hollow tube of the large intestine. And again, 98% are going to be adenocarcinomas. So what oftentimes happens, and we're not going to get into all of the genetics and all of the details here, but what will normally happen is that you have your mucosa, submucosa, and muscularis propria. These are the layers of the large intestine. So what will happen is there'll be certain mutations that you're either born with or that you accumulate over time, and your mucosa becomes at risk. And over time, certain more mutations will occur, which will increase the risk of growths occurring in those particular areas of the large intestine. So we can get growths like this. This one here is what we would call a pedunculated growth or a tubular growth. And as you can see, it has a stalk. And these are going to be the less risky or better polyps to actually see because these can be grabbed a hold of and removed with a polypectomy. Over time, though, if these growths are to remain here and not removed, they can begin to spread and grow into the surrounding area, leading to a carcinoma or a cancer. So that was one type of adenoma. But another one is going to be what we call a sessile adenoma. So again, we look at these layers here, the mucosa, submucosa, and muscularis propria. And again, depending on the types of mutations that occur, we can get what we would call a sessile adenoma. Sessile adenomas are more troublesome than the pedunculated ones because they don't have that stalk that the pedunculated adenomas have. So they're not easy to grab a hold of and remove. So these are going to be the ones that are more concerning because when a patient has their large intestine screened for these adenomas, and these are removed, you don't know how much to remove. And you don't know if you've removed all of the adenoma. So you might have only removed this part and you might have missed a little bit. But with those pedunculated ones with the stalk, you are more likely to know exactly where the stalk begins and ends, and you can remove them accordingly. So the sessile adenomas are the ones that are going to increase the risk for having a carcinoma that is going to be missed with a colonoscopy. And again, over time, more and more mutations will develop in that area, and that cancer can then spread into the surrounding areas, leading to a carcinoma. So those are going to be a very brief overview of the different types of adenomas or polyps that we see with colorectal cancer. We're going to talk a bit more about some other pathophysiology that is important in colorectal cancer as well. There are other types of tumors that can occur, not just the adenomas, but some other types. And one of these includes Kaposi's sarcoma. Kaposi's sarcoma is going to be more likely to occur in HIV positive or AIDS patients, and it's caused by an infection with human herpes virus 8 or HHV8. Kaposi's sarcoma can also be found in other parts of the body, including the face. So it's not going to be just located only in the colon. It's going to be something that can occur in other places as well, and we're going to see this again in HIV positive or AIDS patients. And then another type of tumor that can occur in colorectal carcinoma is the carcinoid tumors. These are actually going to be neuroendocrine tumors, and the thing about these particular types of tumors is that they excrete very large amounts of serotonin. So very large amounts of serotonin can cause some other problems as well. We won't get into this in this lesson, but I wanted to mention here that these are some other types of tumors that can occur in colorectal carcinoma as well. And lymphomas can also be another tumor type that can cause colon cancer as well. Now let's talk about the metastasis of cancer in colorectal carcinoma. So there are actually a variety of patterns of spread of the cancer. So after the cancer has grown into those mucosal layers we talked about before, if it continues, if it is not caught and treated and dealt with, it can spread. That cancer can spread into other parts of the body. And it's going to go to certain parts of the body depending on how it spreads. So there is going to be one type of metastasis known as direct invasion or direct extension. So this is where the tumor itself continues to grow in the large intestine and it just stays in its local area, but it continues to get bigger and bigger. And this is going to essentially be where we see in this image here, there's a cancer that grows and grows and grows, and it grows into the surrounding areas. So it grows within the bowel, and then it may spread past the bowel wall and invade into other abdominal structures and organs. So it stays in the area, and it just slowly grows and grows and grows, gets bigger and bigger, and it starts to go into the abdominal cavity. There's also another mechanism of spread known as hematogenous spread. Hematogenous meaning that it spreads in the blood. So this is where the cancer leaves the bowel, goes through the bloodstream to go to other organs and other organ systems and other parts of the body. So there's going to be several ways that this can happen. So this is where cancer cells from the tumor in the large intestine leave, enter into the blood, and go to other sites. So it can travel via gastrointestinal veins to the portal circulation. The portal circulation is ultimately going to the liver. So normally, most blood is drained from the gastrointestinal system into the portal circulation and ultimately goes to the liver for filtration and for other processes. So if it were to go through those gastrointestinal veins to the portal circulation into the liver, this can lead to liver metastases. So liver metastases are actually going to be the most common type or most common location of metastasis in colorectal carcinoma. These cancer cells from the colorectal carcinoma can travel to other sites though, so they don't necessarily have to travel through the gastrointestinal veins to the portal circulation. They may actually travel through the lumbar and vertebral arteries. So they can go through other circulatory pathways as well. And this is where it's going to lead to metastases in the lungs and the brain. So those are the ways by which cancer cells from the colorectal carcinoma, the tumor in the large intestine, how those cells from that cancer can spread to other sites through the blood. So again, via gastrointestinal veins to the portal circulation to cause liver metastases, or through the lumbar and vertebral arteries to the lungs and the brain. But there is one other mechanism or method of spread of the colorectal carcinoma, and that is through the lymphatic system. So oftentimes, if it spreads through the lymphatic system is going to lead to regional spread. It's not going to go too far, not like what can happen with hematogenous spread. So the lymphatic system is located throughout the body and acts as a way of picking up excessive fluid. And it also operates as part of the immune system as well. A lot of immune cells are located within the lymphatic system to pick up any microbes that happen to enter into the lymphatic system. So a cancer could leave the large intestine and then enter into the lymphatic system, but it's not going to spread too far. It's only going to stay in the region, but it can spread a bit through the lymphatic system as well.
There's one simple hearing hack anyone can use to improve their hearing almost overnight.
Now let's talk about colorectal carcinoma signs and symptoms. So there's going to be 3 different ways a patient is going to present with colorectal carcinoma. One of them is going to be asymptomatic. So the patient may be asymptomatic, but they can have colorectal carcinoma. The cancer itself may not have grown to a point where it's causing the patient any problems. So these patients are going to be detected by screening methods that we're going to talk about in the next upcoming slides. But if a patient is going to have certain symptoms, those symptoms are going to be abdominal pain. So they're going to have some vague abdominal pain that's going to occur, and they're going to have stool changes. This is going to be very important with seeing symptoms and signs of colorectal carcinoma. So stool changes are going to include stool caliber changes. So the patient can have a very thin stool, so they can have what we would call pencil stool or pencil-shaped stool. And you can imagine that if there's a tumor growing within the large intestine, it can slowly decrease the width of the large intestine. So stool going past that obstruction is going to get thinner and thinner. So we can see a pencil-shaped stool or changes in stool caliber. We can also see changes in stool frequency. So we can see alterations in a patient going from having excessive diarrhea to being constipated. So it can go back and forth, diarrhea, constipation, diarrhea, constipation. This can look like irritable bowel syndrome, but if it occurs in a patient that is older, this is going to be a finding that's going to increase the suspicion that this could be colorectal carcinoma. So again, these bowel habit changes can be alternating between diarrhea and constipation. Patients with colorectal carcinoma can also experience weight loss. So weight loss can be an important constitutional finding with many different types of cancers, including colorectal carcinoma. And then another way that patients can come to the attention of clinicians is through other findings, including melena, which is a black, tarry, smelly stool, or hematochezia, a bright red blood per rectum. And this is going to lead to iron deficiency. So I want to make a point here by saying that a finding of iron deficiency in older patients especially is going to be something to look out for. So even if the patient doesn't notice melena or hematochezia, they could still be losing small amounts of blood each time they use the washroom. And this can lead to an iron deficiency anemia. So if you see iron deficiency anemia in especially older patients, then this is going to be a red flag when thinking about colorectal carcinoma. Now, there are some other clinical features that can occur in colorectal cancer as well. So these are going to be due to a large bowel obstruction. We mentioned that colorectal carcinoma is actually the most common cause of large bowel obstruction in adult patients. So again, it's because you can imagine that if the tumor or the cancerous growth continues to grow and grow and grow, it can actually start to block off the lumen or the hollow tube of the large intestine. So it can lead to a complete blockage where nothing can go past, so no gas or no feces. So this is going to lead to particular signs and symptoms. And some of these can include nausea and vomiting. So if everything's backed up in the gastrointestinal system, gastrointestinal motility is going to suffer, and this is going to increase the risk of having nausea and vomiting in these patients. Constipation is also going to be another finding because nothing can get past that blockage. A patient is not going to have any bowel movements. Obstipation can also occur. Obstipation is where there is no passage of feces or gas at all. So the patient is not passing flatus. And then there can be some other signs and symptoms that are related to rectal cancer more specifically. So if the tumor or the cancer's growth resides in the rectum, this can lead to other particular findings that we didn't mention before. Some of these include rectal fullness, so a feeling that there's something full within the rectum or a mass that can actually be felt to some degree. Tenesmus can also be something that can be noted as well. So tenesmus is actually a urge to evacuate the bowel, so that is another finding in colorectal carcinoma. And then a sensation of incomplete evacuation. So after a bowel movement has completed, it feels that you haven't completely had a full bowel movement. There's a sensation that you haven't finished. So these are going to be some other findings with rectal cancer if the rectum is involved in colorectal carcinoma. Now let's talk about ways that colorectal carcinoma is screened for. One of them is going to be fecal occult blood testing, or FOBT. This is also known as stool guaiac test. However, this type of testing is prone to false positives. So this is still used throughout the world in different places. However, it does seem that this test is more prone to false positives than some other screening tests we're going to talk about in a moment, because it may actually detect blood in your diet. Because if you're eating red meat, things like steak, there can be some blood from that steak, from that meat, and that can actually be detected on a fecal occult blood testing. So this is one possibility as to why we can see more false positives with fecal occult blood testing. Now, the newer way of screening for colorectal carcinoma is by a fecal immunochemical test, or FIT test. So this is becoming more and more preferred over the fecal occult blood testing because of the fact that the FOBT is prone to false positives. And then another method of screening, which is not going to be utilized that often for colorectal carcinoma, but can detect some cancers, is a digital rectal exam. Although most times clinicians are going to utilize an FOBT or an FIT, or FIT test. Now, this is going to differ depending on the country you reside in, but some guidelines will suggest screening should begin at the age of 50. We talked about increased age, especially 50 years and older, being a risk factor for getting colorectal carcinoma. So oftentimes guidelines are going to suggest screening to begin at age 50, but there may be cases where this is going to be even earlier than that, especially if a patient has a family history of colorectal carcinoma. If they do, then begin screening at 40, but if there is an even earlier diagnosis in the family, then start screening 10 years before the age of onset. So if a patient has a parent who had colorectal carcinoma at the age of 45, then screening should start at the age of 35. So that is one example. So again, we did mention that younger and younger patients do seem to be getting colorectal carcinoma. So these numbers may change, and in some places they may be even younger than this for screening. But for the purpose of this lesson, and most guidelines do suggest that screening should begin at the age of 50.
If you're thinking of selling your house, want to know how much more you could be getting by using this brand new way to sell? The real estate market.
Now, how is colorectal carcinoma diagnosed? So we talked about some of those screening methodologies that can be used to determine whether a patient is going to get further testing. So one of them is going to be flexible sigmoidoscopy. So this is where the sigmoid colon itself is going to be looked at. It's not going to detect all cancers because you can imagine that the sigmoidoscopy is only going to get to a certain point. It's not going to be able to check the right colon, for instance. It can diagnose approximately 3/4 of cases, but because it only looks at part of the large intestine and misses other parts of the large intestine, oftentimes it's important to continue to have screening with an FOBT or an FIT. And a flexible sigmoidoscopy is going to be performed more frequently. It's going to be performed roughly every 3 to 5 years. Now, the best way of screening and diagnosing colorectal carcinoma is by a colonoscopy, and a colonoscopy with biopsy more specifically. So a colonoscopy is going to be like a flexible sigmoidoscopy, but it's going to have the ability to look at the entire large intestine. This is going to be the most sensitive and specific way of diagnosing colorectal carcinoma and colorectal polyps. And it's going to be performed every 10 years unless abnormalities are found. Different guidelines will determine the frequency of colonoscopies and screenings. So again, most commonly it's going to be a colonoscopy every 10 years, especially if there are no polyps found. And then what's going to often happen is that if there are polyps found, that can increase the frequency of colonoscopies in the future. So follow-up colonoscopies are going to become more and more frequent if there are more abnormalities found. So again, oftentimes the screening and the colonoscopies are going to start at the age of 50, and they're going to continue as you get older. And the colonoscopies themselves carry some risk. There are risks involved with the colonoscopy. It requires anesthesia. There are certain risks that can be involved with colonoscopies. So as a patient gets older, and the older a patient gets, the benefits and risks associated with colonoscopy is going to have to be discussed more rigorously with your clinician or your physician. So again, that's important to also discuss as well. Now, there used to be a way of screening or diagnosing a colorectal carcinoma, and that was by a barium enema. And this is actually not used anymore. This was actually something that would only detect colorectal carcinoma at a late stage, oftentimes stage 3 or higher. But the reason I bring this up is that it has such a classic look to the image that it can be oftentimes an important learning point when learning about colorectal carcinoma. So old images with barium enema and colorectal carcinoma cause the image to look like this. And this is what is called an apple core lesion. It actually literally looks like the core of an apple. But again, barium enema is not used because it oftentimes picks up the cancer too late. And then there's another way of mostly following the trajectory of the cancer once a patient has cancer and is treated, and that is with carcinoembryonic antigen, or CEA. So again, it can be utilized for prognostic purposes. And again, this is going to be a blood test that is not so much for diagnosis, but more for following a patient and determining their prognosis when they have already been diagnosed with colorectal carcinoma. So when they have been diagnosed with colorectal carcinoma and they have a CEA performed, if the CEA is higher, that leads to a poorer prognosis for the patient. And again, this can be important to measure CEA levels prior to treatment and then during follow-up to assess for recurrence. So before the treatment, before chemotherapy and surgery, and then after chemotherapy and surgery, you'll note that the CEA levels decrease. And if you start to keep an eye on that CEA level and it starts to increase again, that indicates a recurrence of the cancer. So that is important to recognize as well. And then a CT scan is important for staging the cancer. So we're going to talk about some of the staging in the next slide. So let's talk about the staging. So the staging of colorectal carcinoma is by the TNM system of staging: tumor, node, and metastasis. So here is a list of the TNMs. So in the case of stage 1, it's either T1 or T2, which would either mean that it is an invasion into the submucosa or invasion into the muscularis propria. And in stage 1, there are no nodes affected and no metastasis is present. Stage 2 is when there is T3 or T4, so the cancer is spread even more. So it's invasion into the muscularis propria and into the serosa, or there is invasion into adjacent structures or organs. But no nodes are affected and there is no metastasis. That would be stage 2. Stage 3 is when there is actual node involvement. So there is metastasis into regional nodes. So it can either be N1 or M2. So if it's N1, it's metastasis into 1 to 3 regional nodes. And if it's N2, it is metastasis into 4 or more regional nodes. So any nodal involvement, but without metastasis, that would be considered stage 3. And then as the cancer progresses, there'll be a high T number, and then there'll be nodal involvement, but then there'll be metastasis. So distant metastasis to those areas we talked about before, the liver, the lungs, or the brain, for instance, some of those areas. So if there is distant metastases, then that would be stage 4. So this is a brief overview of the staging of colorectal carcinoma. Now let's talk about treatment and follow-up for colon cancer. So for non-cancerous polyps, we talked about a polypectomy when performing a colonoscopy. That is going to be very important. So you remove the polyps before they become cancerous. It oftentimes takes 5 to 7 or 5 to 10 years for a non-cancerous or pre-malignant polyp to form into a cancer. So that's why it's important to follow up every 10 years. So you remove the polyps, and then by the time another polyp forms, and by the time you get to it the next time you do a colonoscopy or the next time you assess and look for polyps, then there has been a short enough period of time where you catch the polyp before it becomes cancerous. So that's what you do. That's how you treat the non-cancerous polyps. You do a polypectomy, a removal of those polyps before they become cancerous. If it is cancerous, if there is a cancer into the mucosa, either one of those earlier or lower stages of the cancer, surgical resection of that particular part of the bowel is going to be important. So removal of that part of the bowel. So it's going to be a colectomy, so partial colectomy oftentimes. So if you were to take that part out where the cancer is located, and then you do a primary anastomosis, so you connect the two pieces back together, that would be an anastomosis. So that affected part of the bowel is removed, and then the two parts are put back together again. So that would be an anastomosis. If it is the case of a rectal cancer, in these cases, there is a higher recurrence rate of cancer, and it's oftentimes going to be a resection as well. Adjuvant therapy is oftentimes going to be utilized depending on the stage of cancer. If it is stage 3 or higher, definitely going to have more adjuvant therapy because nodes are going to be involved, and oftentimes there could be a metastasis involved. So you're going to use adjuvant chemotherapy in those cases. And what's going to be used are the following. And some of the regimen that's going to be utilized is Folfox, so folinic acid, F for fluorouracil, and the OX for oxaliplatin. Folfury can also be utilized as well. And in some cases, capecitabine with oxaliplatin can be used. And then in some cases, VEGF inhibitors can be utilized like bevacizumab. If there is distant spread, if it is stage 4 or there's distant metastasis, palliative care is going to be utilized for those patients. And if there is recurrence, and that can occur in some patients, if there's going to be recurrence is going to occur within the first 3 years after surgery. So 90% of recurrence will occur within 3 years of surgery. So that's important to recognize as well. And we talked about CEA levels being important to follow to assess whether there is recurrence of the cancer. So again, CEA measurement, levels that increase, CEA levels that increase after treatment indicate recurrence. So CEA is something to also measure for follow-up purposes. So that was a broad overview of colorectal carcinoma, but if you want to learn more specific details about colorectal carcinoma or colon cancer, please check out my lessons on those specific topics. And if you haven't already, please like and subscribe for more lessons like this one. And as always, thanks so much for watching, and hope to see you next time.
There's a hidden cause of joint stiffness that won't show up on an x-ray. And you probably never heard your doctor mention it. And you sure as heck won't.
So that was the presentation on colorectal cancer. We're going to look now into our textbook. So colorectal cancer, as we see, involves the cancer in basically large intestine and the end of the large intestine, the rectum itself. And it's one of the more common scenes, malignant presentations in the world. Again, it does affect people who are ingesting animal protein, lowering the dietary fiber, too much of a processed foods, people who don't drink enough fluids, especially water, smokers, people who drink more, or use like stimulants like caffeine drinks, people who eat lots of nitrates like laced food like smoked meat and so on. Congenitally, it plays the role as well. Coming from families where there's a history of colorectal cancer naturally increases the risk of someone contracting it. Clinical manifestation, often in the beginning, there are no obvious symptoms. At sort of mid-stage, we start seeing usually the blood in the stool. hematophysis, and that's usually a triggering thing. People go to see a family doctor, they do stool and ova test, they may follow up with colonoscopy, they may find polyps, and then they may take a sample or remove the polyps and find that one of the polyps is malignant. And so by that time, we're moving from mid-stage to late stage maybe, when we start seeing other things, loss of weight, anemia, more bleeding, a loss of appetite, problems with stool in terms of alternate constipation and diarrhea, fever. And so etiologically, Chinese medicine looks at this as external and internal factors. External factors means the pathogen that comes from outside, so often dietary stuff, we mentioned it. And so that creates eventually internal factors. Internal factors mixed with external factors, and emotions, again, ongoing infections, they're not addressed, overtaxations, and so on. So we're going to look at the first pattern in terms of treatment. It's internal accumulation of damp heat. So cramping pain in abdominal region, diarrhea with the blood or mucus in the stool. We have this tenesmus, which is feeling of incomplete evacuation of the stool after people go to the bathroom. So they feel that there's more there, but often they cannot pass the stool. So there may be itchiness and burning sensation in anus, nausea, oppression, and then there may be systemic things like dehydration, dry mouth, desire for cold drinks, feverish sensation. So when we look at tongue, often it's red with yellow coating or greasy coating. Pulse is slippery, wiry, or slippery and rapid. Treatment principle here is clearing heat, benefiting movement of dampness, fortifying spleen, and regulating qi of intestine, so peristaltic motion. So again, we're using here two formulas. So we have pagoda tree flower and Sansevisorba root decoction, so Huai Hua Diyu Tang and Baito Wang Tang Jiejian, so pulsatilla root decoction modification. So in this combination of two formulas, we have Sophora, Hua Huai, Qianhetao, Agremonia, Chisao, Peony, Diyu, Sansevisorba, uses anti-inflammatory and basically blood stopping herbs. We have Baijiang Zhao, Baitong, Pulsatilla to clear the heat and relieve toxicity, but also to treat any possible mucus intestinal entry, diarrhea. Huang Bai, Kushan, Mai Chishan, dry dampness and clear the heat from lower burner, as well as stopping diarrhea. Yi Ren, Quaix, Hopo, Magnolia, Zhangzhi, Atrocholotis. Baizhi, dry the dampness, fortify spleen qi, and disperse accumulation. Baiyang, Tufulin, dispel dampness, clear the heat, and relieve toxicity. Second pattern we're looking at is internal obstruction of the toxins. So we have pain and lumps and fixed location of abdominal region with tenderness and pressure, and diarrhea with purplish blood, and mucus. Again, tenesmus, feeling of incomplete evacuation, full smelling stool, so much smellier than normal, prolapse of rectum, hemorrhoids, difficult defecation, irritability due to feeling of heat, thirst, often person presents with dull gray facial complexion. Tongue body is purple, sublingual veins are purple, coat is thinner yellow, pulse is sort of irregular, rough, tready, and maybe surging or rapid. Treatment principle is transforming blood stasis in the lower jaw, relieving toxicity and regulating the qi of intestines. So we're using two formulas again. So we're using Tao Hong Siwutang, peach kernel and safflower, 4 agents decoction, and sudden smile powder, Shi Xiao San Jiejian, with modifications. So Tao Ren Hong Hua Pu Huang, Dang Wei Wei, Chi Xiao Yizhi, they are there to break the blood stasis and alleviate the pain. Baijing Zhao, Ercha, Ma Chi Shan are anti-inflammatory herb and they clear toxicity. They also regulate blood chemistry, stopping the bleeding and stopping diarrhea. Chuang Lianzi, Melia, Yan Huso Cordialis, Mu Xiang Oclandia, regulate qi, and they're also painkillers. Huang Bai, Jin Yin Hua, Lonicera, dry dampness and clear the heat. Bai Jilian and Bai Cao, clear the heat, relieve toxicity, and they've stopped malignant cells from replicating. Spleen and kidney yang deficiency. So we're looking at potentially hypothyroid and adrenal deficiencies. So we have distension and pain in abdomen that likes the pressure and warmth, persistent early morning diarrhea, enduring dysenteric disorder with diarrhea. Often diarrhea is mixed with mucus, sometimes maybe with some small amounts of blood. Poor appetite, general cold limbs, very sensitive to cold and draft, shortness of breath, lack of strength, low appetite, as we mentioned. Problems with lack of strength in low back, waist, and knees. Person presents with yellowish, pale kind of facial complexion. Tongue body is pale, often pale red, swollen with teeth marks, thin white coating, pulses deep and shreddy, and weak, usually at the back kidney position as well. Treatment principle is to warm the kidneys, fortify spleen at the young level, dispel dampness, and dissipate the cold. So we have, again, approach with the two formulas. So ginseng, Poria, white Atroloris, powder Shenling, Baijisan, combined with Shirshen, one Jiajian, 4 spirits filled with modification. So we have qi tonic, such as Codonopsis, Dangshen, Huangqi, Astragalus, Renshen, Ginseng, Shaniao, Discoria, Dazao, Juju, to supplement qi and fortify spleen. We have Fuling, Yiren, Sharen, Tangzhi as diuretics to regulate qi, drain the dampness, and prevent stagnation. Hezi, Zhi, Wu Weizi are astringent herbs, restraining leakage of intestines and stopping diarrhea. Buguji, Wu Zhuyu, Evodia, supplements the kidney at the young level and stopping diarrhea. Rudoko, Ganjiang, Yin Yang Huang, Fu Penzi, warm the kidneys and enrich the spleen yang and dissipate the cold. Shengma uplifts the yang qi to stop diarrhea. So again, 2 formulas focusing on boosting spleen and kidney yang, stopping diarrhea, stopping the pain, addressing the any masses. Next one is kidney and liver yin deficiency. So we have dull pain in abdominal region, constipation, sometimes stools present pus and blood, sensation of heat in the chest, palms and soles, especially after 5 p.m., dizziness, tinnitus, aching in the lower back, legs, and knees, seminal emission at night for male patients, impotence, emaciation, night sweating, bitter taste in the mouth, dry throat, insomnia, vivid dreaming. So tongue body is red with scant coating, often with fissures or cracks. Pulse is wiry, tready, sometimes deep and tready. Treatment principle is enrich and supplement yin of liver and kidneys and clear the basically heat by using anti-inflammatory herbs. So we're using Zhi Bai D11, Jiajian, Anamaria, Philodendron, Rehmannia pill, version of Liu Wei D11, Rehmannia 6 pill. So this is a known sort of yin tonic with certain herbs that are augmented to address other issues. So we have Shu Di Huang, Shen Di Huang, Gui Banjiao, Gu Zhizi, Nu Zhenzi, Mai Mendong, Shayao, supplement blood enriched yin, Mu Dampi, Chao Zhizi, Jimu, Fuling, Poria, Huang Bai, Zixie, alismatis, to drain the dampness to diuresis to urination, clear the heat, and make the blood more alkaline, cool the blood. Baijiangzao, Banjolian are there to detox the tissue, activate lymphatic system, and basically preventing malignant cells from multiplying, right? Depletion of qi and blood. So often we have this after patients reporting large amounts of bleeding in the stool. After these patients may be more in the senior range, so 65 or older. So the distension, fullness in abdomen, occasional loose stool, so diarrhea with blood and mucus in the stool, prolapse of rectum, hemorrhoids, lack of strength, palpitations, shortness of the breath. A person presents with dull white facial complexion, they look deconditioned, poor appetite, low metabolic rate of digesting foods. So tongue is pale with thin white coating, pulse is steady and forceless or weak. Treatment principle is to supplement qi and nourish the blood, support the spleen, and boost the kidneys. So we use the two formulas, Bajing Tan, 8 treasure decoctions, qi and blood tonic, combined with Dangwei Bushui Tang Jiejian. So Chinese angelica root decoction for supplementing blood with modification. So we have Tai Zi Shen, Huangjiang, Dazao, to augment qi, fortify spleen, generate body fluids. Huang Bai, Baizhi, Fuling, diuretics, dry the dampness, clear the heat, fortify the spleen at the qi level. Dangwei Bai Shao, Ce Shao, Ji Shui Ten, San Qi Fen, Danshen, Shu Di Huang, Go Zhi, Yijiao are used to nourish and supplement and invigorate the blood. Huang Qi, Sheng Ma, bear the spleen yang upward to prevent prolapses and supplement the qi. Tu Zi Zi, Rou Gui, Zi He Che, consolidate the essence qi and supplement the yang of the kidney. So these would be direct treatments. We, again, as we mentioned, we often see patients post-surgically during the radiation chemo treatment or targeted endocrine therapy. So external treatment often means there'll be steaming or soaking herbal decoctions, where patients first steam the pelvic floor and rectum, and then they once they cools down, they soak themselves, so sitz baths. Acupuncture can be used also very effectively here for chief complaints. So for prolapse of rectum, we use governing vessel 20, so do 20 Baihui, CV or Ren 6, Ren 4, bladder 20, and then governing vessel 1. Governing vessel 1 is very hard to treat because no one's going to let you kneel them on a pelvic floor. So often governing vessel or do 1 is replaced by already using do 20 for same effect. Moxa can be applied to bladder 20, CV4, CV6. So here is the explanation. So they're using bladder 20 to reinforce the spleen yang and augment the qi. Moxibustion, as we mentioned, CV4 and 6 lifts the original qi and to stem prolapse. Governing vessel 20 Baihui supplements and affiliates the yang qi. Local points, which again we often don't kneel. Governing vessel 1, governing vessel 20, and CV6 again lift the qi to offset the prolapse rectum and hemorrhoids. In radiotherapy, we treat due to toxicity. Problems with urination, for example, polyuria with burning pain during urination, blood in urine, red tongue with white or greasy yellow coating. So we combine Bajingsan 8 correction powder with Xiao Ji Yin Zi Jia Jia. So combined with field thistle drink. Damp heat in large intestine with indications such as distension, pain in lower abdomen, constipation or diarrhea more than 10 times a day, possible with pus and blood in a stool. We use Gugen, Qinlian Tangjijian, Kudzu wine, Scutellary, and Coptic decoction modification, and Lianli Tangjijian, Coptic regulating decoction modification. In chemotherapy, we rarely see patients treated by colorectal cancer for chemo because the cancer just doesn't respond well to treatment with chemotherapy. So again, prediction usually it's at 5 and 10 years. Close follow-ups with imaging like basically colonoscopy, imaging with the barium, radioactive barium contrast enema are key. Nutrition is the key. Dietary therapy can play a significant role. Often food is the chief complaint or pathological agent that combine with some constitutional weakness. So food post-surgically should be nourishing food. So often these are certain tonics. Here they're mentioning edible bird nest, the shark fin stew, beef, often with tangerine peel. And this is after surgical thing to add animal protein for people to recover. Where we have diarrhea, Fuling and Fuling Yimi Jo, Korean Koix seed congee is used. When stools are dry, constipated, we add usually like kiwi and some other herbs. Chemo and radiation usually means that patients should eat well-cooked food, easily digested. With palliative care and late-stage cancer, often we add more of organ meats and certain herbs such as shanyao, yiminzhou, quercetin congee, and sausage made from pig or cow intestine. Qigong therapy can work really well as well, but the main focus would be food and herbal therapy. So that would finish our lectures on liver, stomach, and colorectal cancer for today's lecture. We're going to shift to one more presentation in which we will see only partial part because it's longer presentations for an hour. We have about 35 minutes. So watch as much as we can, and I put a link there in our chat area so for you to follow up the rest of the lecture. So let's have a look. I'll just fast forward a little bit.
And there's a few things that I'm hoping we can address today. So one is, what is colon cancer? How does it develop? Two is, how can we detect colon cancer and or prevent colon cancer? And you'll see that there's different tests that can be used depending on somebody's preferences and how they work. And then we'll address some high-risk groups. I just put a little bit about my history here. I went to college in Rice University and majored in chemistry. Subsequently went to medical school at UT Southwestern in Dallas with a focus on GI research, and I looked into the kind of cancer pathway that develops in esophageal cancer from Barrett's esophagus. And then subsequently came out to Colorado and, like many people, loved it back in 2004 to 2007. Did an elective with worldwide cancer expert Dennis Ahnen, researching the effect of NSAIDs, which is ibuprofen, Aleve, Advil, and aspirin on colon cancer development. There's some evidence that they may be preventative, at least low-dose aspirin in certain populations. And then did a GI fellowship at the University of Washington with a combination of research in cancer development at the cellular level. Adenocarcinoma is the type of cancer that many GI cancers are, including colon cancer and pancreatic, and then some additional research into hepatitis C. And then I subsequently did an additional year with liver transplant work at Northwestern in Chicago. So March is colon and rectal cancer awareness month, and I think that's why we do this lecture in March most years. And in 2000, President Bill Clinton officially dedicated March as National Colorectal Cancer Awareness Month. And then in 2019, Governor Polis actually also signed a proclamation declaring March to be Colorectal Cancer Awareness Month in the state of Colorado. Here's a kind of the proclamation from Jared Polis, and then the Capitol building has generally been lit up in blue, or the Denver City and County building, sorry, every year for Colon Cancer Awareness Month. And then additionally, Empower Field and Ball Arena are often lit up for colon cancer awareness. Colon cancer is common, so this is not a cancer that you hear about rarely. If you talk to your friends and family, and many of you probably have, somebody will know somebody who had colon cancer or have been personally affected by it. There's a few people I have up on the slide here, many of which, or most of which you may have heard of. Chadwick Boseman was probably the most recent kind of famous person to have colon cancer at a very young age, and a few other folks here. So it's something that we see in the news regularly with celebrities and other well-known people. So kind of moving into the meat of the presentation, we're going to talk about colon cancer, how it develops, and then important things to keep in mind is it's common, as we discussed. It is lethal, and it is actually preventable in most cases. So looking at kind of a diagram of a person here, and you can see the colon outlined, which is this foreground image, and then the small bowel or the small intestine is pictured behind it. And the colon's about 4 to 5 feet long, and it has a few major segments, as you can see here in the diagram. The top is the cecum, and then we progress through the ascending colon, since it's going up on the right side, over through the transverse colon, down the descending on the left side, through this twisty area called the sigmoid colon, and then out into the rectum, and then your poop comes out. So that's kind of how we work naturally. And there's a lot of symptoms and signs that can be concerning in the GI tract that are often worth talking to your primary care doctor or a gastroenterologist about. And these include things such as changes in your bowel habits, blood in the stool, change to the shape or character of your stool, unexplained weight loss, challenges with abdominal pain, anemia that's developed and is new without an obvious source. Anemia is a low blood count that can sometimes present with fatigue or just be picked up on your regular yearly labs. And when we do colonoscopy, which we're going to talk about a little bit later, we basically can put a scope into the colon and take a look at the entire colon. And we can look for colon cancer, and then additionally we can look for little precancerous pieces of tissue, which are called polyps. And looking at that tissue, often we have an idea of whether it's something that's concerning or not, and often we'll remove polyps because we think most colon cancers come from polyps, and by removing them we can prevent colon cancer. I've put a few pictures in here. These are a few pictures of, the first one here is a colon cancer on the wall of the colon, and then over here is a polyp, and then here's another polyp, different type, and then here's kind of a large polyp that may have cancer in it. So these are all things that we can encounter in the colon. This is the sequence that we kind of think about in research and that we think is how cancer develops. And so what you start with is kind of a little tiny bump on the wall of the colon. So this diagram is representing the colon wall, and we're seeing the inner lining called the mucosa, and then the submucosa, and then the serosa below that. With colonoscopy, we're mostly working within the mucosa, which is also where colon cancer will start and develop. And so you can see a little bump of cells, and then it starts becoming a small polyp, and then subsequently into a large adenomatous polyp, which is generally the precancerous type of polyp. And then subsequently, part of that polyp may develop cancer within it, which can then spread, and you can see in this little white area of cancer spreading into the lower tissue, into deeper tissue, and then this would kind of be cancer that hasn't advanced to be a true cancer, and we call it in situ. And then subsequently a true cancer, which can no longer be removed with a colonoscopy but requires surgery and may require chemotherapy or radiation or other things. And this progression from kind of small polyp to cancer takes on average around 10 years. And so that's why for screening colonoscopies, generally the interval for somebody who's low risk and had an unremarkable colonoscopy is about 10 years, because we're thinking we got a good look, we didn't see anything. It would be 10 years before you're able to progress to anything significant once you've even developed some of these small polyps. And then notably, as it says on the bottom of the slide here, most polyps or adenomas do not become precancerous. But almost all colon cancers, 95% plus, will develop from adenomas. So as gastroenterologists doing a colonoscopy, we remove all the polyps. We don't know how to tell which one's going to progress, which one's not. And we remove all of them, and then we kind of hope we're getting the ones that, given enough time, might be able to progress to a colon cancer. So looking here, here's a few more pictures of different types of polyps. We can see this is a small hyperplastic polyp, which often are not precancerous. Here's a pedunculated polyp. It has a little stalk. This is a spreading polyp, which can be a little bit more challenging to remove. And then here's a large polyp, and you can see in the background it gets kind of bigger and beefier back there, and that may have cancer or what's called high-grade dysplasia within it, which we treat very similarly to a cancer, except that generally we can remove these with the colonoscope. And then here's a large polyp with a different type of imaging we sometimes use to highlight that type of tissue called narrowband imaging. Here's a couple more pictures of subtle polyps that we pick up more often nowadays. Colonoscopes have improved quite a bit. We use high-def scopes, and so they can really highlight these subtle changes in the tissue that were hard to see 15, 20 years ago. And now in the last 5 and 10 years, textbooks have been written about this, and we get a lot of training. Here's a really subtle one here that is quite hard to see on the screen, but is just kind of a flat raised area there that is a precancerous polyp or an adenoma. And then here's a couple more pictures of colon cancer. So you can see quite a bit different from the other photos I showed. This is not removable with a colonoscope. In one case on the right, it's kind of nearly obstructing the colon lumen, so it's kind of gone in a big circle there and growing inward. And then on the other one here, it's just on the side, probably taking up about half the circumference. And these, if I tried to remove this with the scope, the problem is that it would have grown into those deeper tissues and we wouldn't be able to be successful, in most cases at least. Looking at cases of colon cancer in the United States, this is a common cancer. So globally, it's the second most common cancer in women and the third most common in men. And it's the fourth leading cause of cancer overall. There's about 150,000 Americans that are diagnosed with colon cancer each year, and about 50,000 Americans will die from colon cancer, which is about 8% of colon cancer deaths. What's important is most cancer screening that we do, if you think about prostate, breast, lung when it's appropriate, we're really looking for the cancer, and then we're trying to treat and remove the cancer hopefully early so that we can cure it. With colon cancer, we're really lucky because it comes from these polyps that are removable. It's preventable in many situations. So by going in with a colonoscope, removing polyps, we can prevent them from turning into cancer down the road. And you can see here, obviously, Colorado has its similar representation in terms of cases for the population. So this is a slide kind of showing the good news and the bad news in terms of colon cancer in the last 40 or so years. Colon cancer has decreased overall about 40% since 1987 in patients over the age of 50. And that's really been with the advent of screening. Colonoscopy and other screening modalities have to some extent reduced mortality from colon cancer. Unfortunately, we have seen an increase in cancer in those that are younger patients under the age of 50, in particular in an age group that's in 45 to 50. And that was a big reason for the push to change the screening age in the last few years that you may have heard about or not, from 50 down to 45. And so now we recommend average risk colon cancer screening. So somebody who's feeling great, doing great, no problems, no history in their family of colon cancer, that you get screened through some modality starting at age 45. And that's documented here with this significant upswing, about 51% since 1994. Now these numbers are small, but this chart on the right is ages 20 to 49, and most of these cancers are in that 45 and over group. It's thought that this uptick or rise in colon cancer in the young is likely related to diet changes and increased amounts of ultra-processed foods, and then additionally a more sedentary lifestyle and increasing rates of obesity. So if we look at some risk factors for colon cancer, there's a number of them. So different cancers have different risk factors. It doesn't always mean you will get the disease, and a lot of things, all things in moderation, right? Eating cupcakes isn't good for you, but they're tasty, and occasionally it's probably nothing wrong with it. So with colon cancer, country of origin has an impact that may be more diet and genetic related than something within the country itself. And then other demographics, age, as we just discussed. Interestingly, males and females have a little bit of a different risk for colon cancer year to year. Men are a little bit higher risk for colon cancer if you look at any single age group, but women live a little bit longer, and it's just long enough that they have about the same lifetime risk for colon cancer as men. And then race and ethnicity can be a risk. We used to see much higher rates of colon cancer in the African American population. To some extent, other populations have caught up with this increasing rate of colon cancer in the young. Socioeconomic status, which may be partially diet related, and then obviously family history is a big factor for colon cancer. If we look at family history and lifetime risk for colon cancer, what you can see here in this chart is showing FDR as first degree relative. So lifetime risk overall about 5% for most of us, but as you have relatives affected, your risk starts to go up. It's about twofold risk, so double that in somebody who has a first-degree relative with colon cancer. A first-degree relative over 50 goes up to about a fourfold risk. 2 first-degree relatives, somewhere in 3 to 4, and then greater than 2 first-degree relatives, or a syndrome we'll talk about in a minute called Lynch syndrome, which is a genetic syndrome, the risk really starts to go up quite a bit. And so these are groups that we really want to catch, and it's important as much as possible to understand and know your family history. If you're able to, and if you're adopted, talk to your doctor about whether screening is indicated and what might be best for you. And so this kind of just shows, screening intensity. As your risk goes up, we're going to look more frequently with colonoscopy. For high-risk groups, colonoscopy is really the only screening test that's recommended because of that increased risk. With Lynch syndrome in particular, we end up doing colonoscopies every 1 to 2 years in these patients because we know that if we can detect polyps and remove them early, we can prevent them from turning into cancer. And that population in particular advances quite quickly from polyps to colon cancer. So looking at some of these other factors, importantly, as we just discussed, some of the demographic factors, lifestyle factors. So smoking is not just a risk for lung cancer and heart disease, it's a risk for colon cancer also. Physical activity helps to reduce that risk. Significant alcohol intake can be harmful. We used to say that there probably was some healthy amount of alcohol, red wine maybe is good for you. That data has really kind of gone away in the last couple years. Some alcohol is probably safe, but there is no healthy amount of alcohol anymore. So recognize that it's not really doing you any favors, but if you want to enjoy a drink occasionally, there's nothing wrong with that. A couple things in the diet group that are always interesting to note. Number one, a diet that's high in red or processed meat. In Boulder, I often get a lot of questions about, well, I eat, a friend has a farm, and these are grass-fed cattle and well taken care of, and they're different than the kind of industrial farming cattle. I haven't seen any studies that have looked at the differences between those groups. So all I can say is red meat, and my mom won't want to hear it, but pork is on that list too. And so avoiding red meat or limiting red meat can lower your risk for colon cancer. Fiber will reduce your risk, so a good high fiber diet. Low fruits and vegetables, so if you're not getting a lot of fruits and vegetables, a little bit higher risk for colon cancer. One that is generally specific to the GI tract is this charred, broiled, grilled foods. So foods that are really cooked at a high temperature, have a nice char on them, do seem to increase the risk for colon cancer a bit. And then ultra-processed foods, which generally is foods at the store that have chemical ingredients that you don't have in your house. These have been associated with increased risk of colon cancer too. And again, all things in moderation. I think it's very hard to be perfect here, but recognizing what things you can do for your health, I think, is always good. And then the last one, very important, failure to get screened. So probably one of the biggest risk factors for colon cancer is not having any type of screening after the age of 45. And again, just looking at this, deaths from colon cancer, it is a lethal disease, 606,000 deaths in the United States, 8,000 in Colorado. So here's kind of another picture, another diagram looking at how colon cancer develops. And as we talked about, when you have a polyp, it has not grown into this deeper tissue. Once you have a colon cancer, it's grown into these deeper tissues. It can no longer be removed with a colonoscopy, but still can be taken out surgically generally. And then as cancers progress, the stage 2 cancer is spreading deeper into the wall, and it may be getting over towards the lymph nodes. Stage 3 has gone all the way through the wall of the colon and is involving lymph nodes. And then stage 4 means that it has spread to other organs such as the liver, which is generally the most advanced type of cancer. Our effectiveness at treating these decreases as cancers become more advanced. So in general, a metastasized colon cancer that has gone to other organs has a 5-year survival less than 5%. I will say the oncologists have improved a lot in the last few years, and they do have better chemotherapy and medications than they used to. But generally, for all of us, I would say we would want to avoid this if possible. And here's just kind of a 5-year survival rate of the different stages of cancer. So obviously we do pretty well in the early stages, and then the outcomes go down as we get to more advanced cancers. So early detection really is critical here. Ideally prevention, but at least finding cancers in an early stage leads to much better outcomes. So in terms of things we can do, again, we can always have an impact on our lifestyle, and we can have an impact on diet. In terms of cancer progression, so we know that being overweight and not being physically active, both have been linked to colon cancer risk. As we talked about, diets high in red meats, including beef, pork, lamb, and liver, if you like liver, and processed foods, so hot dogs and lunch meats can all raise colon cancer risk. Generally, the best diet for this would be a Mediterranean diet. Plant-based diets can also be beneficial in terms of colon cancer risk. A history of smoking and ongoing smoking increases your risk for colon cancer significantly, and it does start to drop after you quit smoking, and so it really has an impact even if you're somebody who's smoked for 30 years or longer. And then alcohol in general, the recommendation for men and women is for men less than 2 drinks a day and for women less than 1 drink a day, and I think just recognizing that this is a treat and there isn't an amount that's going to be good for you. There is a protective factor. We talked about that. I did some research in this when I was younger, but low-dose aspirin in some groups that are high risk for colon cancer and also have an elevated risk for cardiovascular disease can reduce the risk to get polyps and colon cancer. That's balanced with the side effects and risks of aspirin, which is an increased risk of bleeding, potentially stomach ulcers, and strokes. And so it's not something we recommend to the general public, but in certain groups it can be beneficial depending on risk factors. And this is something to talk to your doctor about potentially. And then screening. Kind of looking at, again, how we progress from this normal tissue to a small polyp there that is really not even visible, and then a visible small polyp, a larger polyp, and then a cancer where it's changed and it's now invading into those deeper tissues. We'll look at ways that we have to detect colon cancer and detect polyps. And ideally, we want to find things as early as possible. So there are stool tests which allow early detection primarily of colon cancer. They do find some of these large polyps. And then there is prevention, which generally is colonoscopy with polypectomy. So going in with a scope and taking the polyps out before they advance to these to cancer or even advanced polyps, which are a little bit more complex to remove. So number one, here we have a stool-based test that's showing up there called a FIT test. These are tests that used to be called FOBT. Now they're FIT fecal immunochemical testing, and they look for blood in the stool, and your doctor may order this or do this occasionally. Additionally, there's another test that we're using now called Cologuard, which looks for both blood in the stool and cancer cells. So because those cancers will let kind of shed cells just like our skin does, Cologuard can detect either and, I guess, the cancer DNA and blood in the stool. We'll talk a little bit more about it. It does not differentiate between those in terms of the result you get back. You just get a positive or a negative. And if any of these stool tests come back positive, so either the FIT or the Cologuard, you have to follow through and have a colonoscopy. If you don't have a colonoscopy, you shouldn't have done the test in the first place because you had a positive test and you didn't go do the test you needed to do to figure out what's going on. So it's a two-step test, basically. And then additionally, testing for blood can, in some cases, detect other things. So often it's positive and we don't know why. We do a colonoscopy, we don't see, but certainly it can be positive from things like hemorrhoids, ulcers, bleeding lesions that can occur in the colon that are not precancerous or cancerous. And so generally, the main thing with the FIT test is just to follow the directions well in terms of what you're supposed to eat and do to make it as effective as possible. And then Cologuard's newer. It's been out now for about 6 or 7 years. And again, it looks for blood and then also cancer DNA. And it needs a full stool sample. So it's a little bit different. Instead of the little smear on the card, here you basically poop in a box and you mail it in, and then you get a result mailed back to you. So when we look at detection rates, so non-invasive assessment for cancer DNA and or blood in the stool, which would be a stool sample, negative means nothing detected, positive means it detected blood or DNA. And here are our results. So colonoscopy, we detect most, if not all, large precancerous polyps. These are those big adenomas that you worry are going to progress to cancer. Cologuard detects about 35 to 40% of them, and then FIT test, which is just the blood, not looking for cancer DNA, drops to about 25%. So the challenge with these tests is you're not picking up really the most important polyps that are out there, which are the ones that are likely to progress to colon cancer. This is kind of another way of looking at some of this data. So finds colon cancer. So this is, will the test be positive and detect a colon cancer that's in you? The FIT fecal DNA, that's the Cologuard, so it's testing for blood and cancer DNA, about 92% chance. It does detect most colon cancers. FIT testing, so that's just the blood test, 75 to 85%. And then colonoscopy, rarely we won't see one, but it's about 95% or a little higher. Finds high-risk polyps, again, those are those high-risk polyps that we don't want to miss. Cologuard, about 42%. FIT testing, pretty close, but 30 to 40%, and then colonoscopy, again, greater than 95%. And then false positives. The FIT testing is listed here as less than 4%. My experience has been it's a bit higher than that. And then Cologuard, 12%. That can vary too, but certainly getting a false positive is not uncommon with these stool-based tests that then subsequently send you for a colonoscopy, and myself or one of my partners looks and says, it looks good, don't do that test again because it may come back positive and you'll be sent right back. And then in terms of this risk of missing cancers, about 1 in 5 with FIT, about 1 in 13 with the Cologuard. And then colonoscopy, what we mentioned here is what we call interval cancers, which is cancers that develop within the screening intervals that are recommended for colonoscopy. And so those are rare, but they can occur. And so when we look at this, again, what we want to do is prevent development to colon cancer, but some test is always better than no test, and so early detection is still beneficial. Finding cancers at early stages really improves your life quite a bit, both in your likelihood of surviving and what you have to go through to be cured. And so this is a picture of what we do with colonoscopy. We looked at this picture earlier of the colon, and you can see here, this is a scope that's inserted into the colon. That's the colonoscope, advanced up to the very top of the colon. And then literally we are looking around with this camera, trying to find anything that looks abnormal on the walls of the colon, with the hope being that we're going to find and remove polyps or find a cancer if it's there. And here's an example. This is a colonoscopy. This is a snare. And so through the channel inside of the scope, we can put little devices down. It has a little wire loop here. You can put the wire around the polyp, and then you close the snare and cut underneath the polyp, and you can remove it. And that's generally the main way that we remove most polyps nowadays with colonoscopy. Here's a picture of a CT colonography. This is generally not as well covered anymore by insurance and not gotten as often. This is another way to look for polyps and cancer in the colon. If it's positive, you do end up needing to have a colonoscopy. The general downside to CT colonography is it involves a colon prep, so you got to clean everything out so that the radiologist can see. Then you have to have air kind of blown up in your colon so that they can inflate it really well and have the polyps stick out. And then subsequently they do a scan. Challenges with CT colonography, one is that to make it cost effective, they effectively ignore small polyps. And so the guidelines that are out there from the American College of Radiology say that you don't need to report any polyp under 6 millimeters. For us in GI, we like to remove little polyps. They're easier to remove, they're less risky to remove. That's kind of what we prefer in general from a risk perspective. So waiting until polyps grow over 6 millimeters is less than ideal. And they also include that polyps under 1 centimeter, you can do a follow-up CAT scan in 3 years, which again to us is kind of just waiting for that polyp to progress to something worse. But it's an interesting technique, and it does work in certain selected patients, those that may have a difficult colonoscopy, or for some reason in discussing with their doctor, this can be a good option. So looking at colonoscopy, which as we discussed is the most effective test.
Okay, so we're going to stop here. And I put the link there for you to see the rest of it. So for next week, we're going to look at ovarian cancer and cervical cancer. So if you have a chance, please look in our textbook. Looking forward to see you next week. Bye, everyone.